She said she'll join.
मैं करती हूँ.
Drop her a WhatsApp message कि madam please we have started the webinar.
Hello.
She
Yes, ma'am.
3, 2, 1. We are live now, sir.
Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Synergy 13 webinar on the topic Blueprint of High Performing IVF Lab. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce the convener of the webinar, Dr. Monica Singh. Dr. Monica Singh is National Executive Member of ISAR. She is President of Elect Bhopal Officer Gynec Society. She is Founder President of ISOPUB Chapter of Bhopal. She is also a convener of Symbiosis Series, Synergy Academic Club, and Perfection Series. Over to Dr. Monica Singh.
Thank you, Dr. Vishal, for that nice introduction. And we will start today Synergy 13, episode number 13 of Synergy Club in association with Rajasthan chapter of ISAR, MP chapter of ISAR, and the Bhopal OBGY Society. I'm very happy to announce that we have been granted 2 ICOG points for this webinar for everybody who's watching it. And we are very thankful to President Rajasthan ISAR, Dr. Gunjan Jain, immediate past President Rajasthan ISAR, Dr. Naren Gupta sir, President BOGS, Dr. Abha Jain Madam, and President MP ISAR, Dr. Archana Baser, for granting us permission to carry on this webinar under the aegis of these prestigious organizations. And today we are honored to have amongst us our chief guest, Dr. Archana Baser and Dr. Gunjan Jain, our guests of honor, Dr. Abha Jain, Dr. Randhir Singh, Dr. Nitish Murdia, special guest, Dr. Naren Gupta, Dr. Brajpala Tiwari. Myself and Dr. Randhir are the conveners for this program, and we've got 5 coordinators with us, Dr. Purva Bhatko, Dr. Nandini Bhati, Dr. Shweta Agarwal, Dr. Richa Samadia, and Dr. Shikha Gupta. I'll just walk you through the program. So this program is consisting of 2 talks, 2 lectures, and a panel. The talks are by eminent speakers in this field. Dr. Rajvi Mehta will be speaking on how to start strong, the essentials of a high-performance IVF lab. Dr. Prateek Makwana will tell us level up innovations which can reshape the IVF lab and improve your results. Then we have a wonderful coffee break. In fact, a coffee academic session with Dr. Priya Kannan and Dr. Manisha Bajpai, where they will decode the IVF lab and tell us troubleshooting and the foundation excellence to add on innovations. Before their moderation, we have got a wonderful galaxy of panelists with us. You can see as many as 12 panelists are assimilated in front of us who are all experts in their field. And I'm sure we are going to have a wonderful discussion amongst all of them. So I'll start by inviting and welcoming our chief guests. You have to tell me, Purva, if the chief guests have joined. Otherwise, we can wait for them or... Okay. So Dr. Shweta and Nandini, please make a call to Archana madam and Gunjan ma'am.
Ma'am, they
Yes,
have
ma'am.
not yet joined. Yes.
Yeah, please make a call to them.
Yes, ma'am.
Please call them personally. One of you can call Dr. Archana Baser. One of you can call Dr. Gunjan Jain. Our guests of honor are, I don't think Abha Jain madam, Randhir, Dr. Randhir is joining, and Nitish. Could anybody talk to Dr. Nitish, Manisha? He did not pick up my phone. So we'll move on to the special guests. So just please keep calling all the dignitaries. You can divide Purva, Nandini, and
Yes, ma'am, I'm calling them.
so we will begin by introducing Dr. Naren Gupta, who is the most punctual dignitary here, who joined just on time, and it is a great pleasure. Our friendship goes back decades, isn't it, sir? So
Yes,
we
yes, Dr. Monica.
we have practically established IVF in the beginning phases of the late 90s and early 2000s, Sir was active in the state of Rajasthan. We were active in the state of MP. And those were the times we didn't have so many webinars. So whenever we used to meet, we used to discuss our patients and problems and new technologies. And that is how we got updated, especially in national and international conferences. Dr. Naren Gupta is the immediate past president of Rajasthan ISAR. Sir is working as consultant gynecologist and IVF specialist at Vivekanand Hospital and Fertility Center in the Pink City of Jaipur. Sir is the past secretary of Jaipur OBGY Society from 97 to 99, the editor of Infertility Update newsletter, and chairperson of ISAR Rajasthan chapter 23 onwards. Sir is also past scientific executive MPS and invited to several national and international conferences as a guest speaker and expert. He has got clinical experience in IVF for more than 25 years. He has been an avid academician, presented several papers, and a member of FOXI, ESHRE, IMS, ISAR, IFS, NARCHI, IMA, AGE, ISAR, and many other organizations. The stage is all yours, sir. We would like to have a few words from you.
Yeah, am I audible?
Yes, sir.
Thank you, Monica, for including me in the program. And I think the subject is really relevant in today's world, where many IVF labs have been set up in India with the embryology training and all this. So I think we have a lot to learn from this webinar. Dr. Manisha and other guests, they are here to enlighten us. So thank you very much for including me, and you can carry on.
Okay, sir.
Thank you so much.
Thank you so much, Naren, sir. And I think we will consider you as our chief guest, guest of honor, and special guest all in one.
Oh, all in one. Thank you.
Because of you, we can start the program till the dignitaries
sure.
join.
Thank you so much.
Yeah, you can please tell me what to do.
Ma'am, Dr. Gunjan Chen, she is not able to join in because of some technical glitch. Somebody can directly, because she is there in the waiting room.
No, there is no
But
waiting
there
room.
is no waiting.
She has gone to ICU.
Might be she has joined from the audience platform,
sir.
not from the faculty platform.
Vishal, could you please talk to her?
Yes, madam.
Dr. Vishal, please call Dr. Gunjan Jain, madam, and tell her and give her the faculty link. I have already forwarded the faculty link to madam.
Yes. Yes.
Okay. Purva, please, can you do that?
Yes, ma'am, I'm coordinating.
Please. So just forward her the faculty link so that she can, Braj ma'am has also joined. So we are very honored to invite amongst us Brajbala ma'am all the way from Japan. So madam, which part of Japan are you in? Let us see a little bit of the beautiful country. हमने सोचा आप फिजी माउंटेन के सामने खड़ी होंगी. Ma'am, you're muted.
It's 9:30 now, so I'm taking train back to hotel.
Okay.
I'm at railway station.
Acha, yes. Yes, it must be already.
Thank you so much. Thank you so much for
So,
keeping me in touch with academics.
So Braj ma'am, today we are discussing the intricacies of IVF lab. So this webinar, in fact, when Manisha and I discussed it 1 month back, she was thinking, madam, you keep 50% clinicians and 50% embryologists. But
Great.
But Manisha, this is going to be your show. So please keep it star-studded with our star embryologists, because we want to know from the embryologists what they want in the lab. Clinicians are all the time they are speaking. But we want to know embryologists, what they do. They are the magicians. They are the magicians in the lab, and we want to learn from them. So, ma'am, just a few words. Madam is right now the secretary of MP ISAR, which is a very strong organization looking after IVF activities in our state of Madhya Pradesh. Madam is also the past president of Indore OBGY Society, the vice president of Indore Menopause Chapter, past vice president IMA, and very active in ISOPAB as well. She is also the chairperson of the Environment. We are so thankful you could join us, Raj ma'am, and have a very nice vacation.
Thank you so much. Thank you so much.
Thank you, madam.
Number 12 for your safety. Please stand behind the yellow line.
Madam, would you like to say a few words?
Good evening, everyone. So thanks for making me part of this important webinar. Basically, IVF lab is the heart of IVF. So that is very, very important. And the advancement in IVF lab and embryology is really going to give us more success for our patients. So I am looking forward to listen all to whatever extent it is possible to listen, because I will be taking train. So thank you so much, Monica, for making me part of this. Okay, bye-bye.
Thank you. Thank you, Braj ma'am, for joining from all the way from Japan. We are really grateful to you. And now I can see on the screen several dignitaries. Dr. Sanjay Shukla is there. Renu madam has joined.
Yes.
Archana ma'am also joined.
Yes. Archana ma'am is there?
Yes, ma'am. She has joined.
Okay. Archana ma'am, welcome ma'am. Welcome, welcome Archana Basair ma'am. We would like to have a CV, please. Our chief
Thank
guest.
you so much. Thank you so much, Monica.
I would like to welcome amongst us the chief guest for the evening, the program that is Dr. Archana Basair, who is president of MP ISAR. Madam is also the past VP of Foxy. She is consultant OBGY and IVF specialist at Akash Hospital, Indore. Madam has had several allocates to her credit. She is the Guinness World Record holder for removing the largest uterine tumor. She is the Vice President Foxy 2020, organized the very successful AICOG 21 in Indore, and ISAR Indore is actually 2016, as well as there was an earlier ISAR in, I think, ma'am, 2005. Yes, the two ISARs in Indore, madam has been, there. She is the fellow representative of AICC RCOG West Zone. She has been the imaging science, she's the imaging science committee chair, as well as she was the Foxy imaging science chair. So, madam, we are very honored to have you amongst us. And it was my, a great wish that the MP ISAR activities under you should be highlighted by the Synergy Academic Club. So, madam, the stage is all yours. We'd like to have words of blessings from you.
Good evening, everyone. Thank you, Monica, for really kind introduction. It's always you're so crisp with your programs, and good to see all the friends on the dais. And I'm really happy that you are taking the MPSR torch. You are keeping it, going along with other societies as well. I think this is the time we are living, that it's good to have collaborations rather than just one society doing the program. That is called the connect. You are connecting with everybody online. And I think it's very important that IVF lab, as Braj has also said, that it's the heart and soul of IVF. And we clinician are a little bit, when it comes to the IVF lab, we say, okay, this is not our subject, or this something which we can may not invest our too much of time, not the money. But I think this is what Monica has brought in this webinar today, is to learn about the IVF lab nuances, so that it will help improve us our results. So all the best, Monica and the team of MP ISAR and everyone who has joined on this platform, for a good learning from this webinar. So thank you very much and all the best.
Thank you. Thank you so much, Archana ma'am, for those nice words. And our chief guest from Rajasthan, ISAR, is also with us. We welcome President Rajasthan ISAR, Dr. Gunjan Jain, madam. Welcome, ma'am. And you are heading one of the most active states in IVF as far as, ART is concerned. The state of Rajasthan is looked up to because you have, the Indra IVF, the pioneers over there. You have Dr. Makwana, you have got the pioneers over there. So, madam, I would take the honor of introducing you. She is Director, Jain Fertility and Mother Care Hospital, and started this hospital way back in 97. Madam will be leading ISAR Rajasthan as the chairperson from 2025 to 27. She took training in Germany under Dr. Tinberg and fellowship from Stanford, California. She has trained more than 500 doctors in fertility and has more than 35 years of experience in this field. Madam, we would like to have a few words from you.
Thank you, Monica, and thank you, Manisha, for bringing me to this platform. It's really a pleasure to be here. And as already mentioned, Monica, your crispness and the the webinar that you have brought in front to introduce all the young and experienced lab workers like our embryologists who deserve, the best because they are the ones who are delivering actually behind the scenes. But, there is something that I would want that, there should be a introduction with our patients also. The patients should know who the embryologists are. And I think the connect will become better and the faith that we'll impose in our patients will be more and more. So thank you for calling me on this platform and wish you all the best.
Thank you, Gunjan ma'am. And you have given us food for thought. In fact, when we have coffee with Manisha and Priya, we could have a question wherein these two ladies could discuss whether the clinician and embryologist should have a chit chat with the patients along with them.
Actually, yeah, because in our hospital we do that, Monica, and the patient always sees the embryologist, and whatever is happening in the lab is conveyed directly by the embryologist. So they have a lot of faith, in what is happening, and they can discuss what kind of transfer they want, when they want, whether they want to go in for freeze-all protocol or not, benefits, and they clear all their doubts. So I think that's a very good thing to do, and if we introduce it in more and more clinics, it should help our patients more and more.
Absolutely, madam. Absolutely. And we are so thankful. We would be really happy if you could stay in, and though it's a long webinar.
Absolutely. Yeah. No, I'll be here.
Thank you so much, madam. And now we have already introduced our special guest. We have with us our guest of honor, Dr. Randhir Singh, who is also my co-convener. Can I have his CV? Dr. Randhir is a friend of many of us, and of course, he's my better half, ESHRE certified embryologist and a managing committee member of ISAR. Together, we manage the Bhopal Fertility Endoscopy Center in Bhopal, which was the first center in Bhopal established in 2003. So, would you like to speak a few words, Dr. Singh?
Thank you, Dr. Monica. Actually, the IVF is the core part of the IVF success rate. And as the Gunjan ma'am also told, and Archana Base madam also told, interaction with the patient, because there should be a both hand. The one when you clap for the success, one hand is a clinician and one hand is the embryologist. So they both should have a counseling with the patients. And today webinar, I have seen you have got the very good people. So I think without wasting time, we can continue and we'll all will learn what are the new technologies and what are the best for the patient for the best result in every IVF at the minimum cost.
Thank you, Dr. Randhir. And we are very honored to have our guests of honor today with us. We are still waiting for Dr. Nitish if he can join, and Dr. Abhajan. We'll try to, welcome them whenever they join. So now any building, when it is built, it is stands on pillars. So this webinar might appear to you a very, fancy, complete star-studded webinar. But when we started, it was all bits and pieces getting together. So all these people, Manisha is the key person behind this webinar. I give 100% credit to her for getting the team together. I have done absolutely nothing, and everything else has been done by my program coordinators. The biggest coordinator is Dr. Vishal Dave, the medical advisor from INTAS. Thank you, Vishal, for always being there.
Thank you,
And
madam.
I have got 5 very, very able and smart gynecs from Bhopal with me. Dr. Purva Bhatkur, who is also assistant professor at GMC Bhopal, my alma mater. Dr. Nandini Singh Bhati, also an assistant professor from GMC Bhopal. Dr. Shweta Agarwal, a known IVF specialist from Ashoka IVF Care Center, Bhopal. Dr. Richa Samadia is HOD Reproductive Medicine at Bansal Hospital, Bhopal. And Dr. Shikha Gupta is director of Deep Shikha Hospital, Bhopal. So these, gynecologists have worked with me day and night and got this program together. So we thank them. And now I give the command to Dr. Purva Bhatkur, the senior most coordinator, to take the scientific program forward.
Thank you so much, ma'am. So moving to our session 1, that is starting strong essentials of a high performance IVF lab. To chair the session, I invite Dr. Renu Makwana ma'am, Dr. Veronica Iron ma'am, Dr. Nibha Mohan ma'am. Dr. Renu Makwana ma'am, madam is presently the director of Vasundhara Hospital Limited, founder, chapter secretary, IMS Jodhpur, Joint Secretary ISAR Rajasthan Chapter, Central Executive Member of Society of Fetal Medicine, President of Jodhpur Menopausal Society. She is recipient of various awards like Young Scientist Award, Veer Durgadas Award, and Marwar Achiever Award. We welcome you, ma'am, to chair the session.
Thank you.
Next, we have with us Dr. Veronica Iron. Ma'am, Madam is presently the director of Dr. Veronica UL IVF and Fertility Clinic. She is presently Joint Treasurer, Chhattisgarh ISAR. She is National Faculty of ISAR, IFS and FOXY. She has held various executive posts in ISAR, Chhattisgarh, FOXY Infertility Committee. She also had been a chairperson, co-chairperson in ISAR to 2012 Raipur. We welcome you, ma'am. Next, we have Dr. Nibha Mohan, ma'am. Madam is presently senior gynecologist of Patna. Due to some reasons, she is not joining at present. Now I hand over the session to our to our chairperson to introduce our speaker, ma'am.
Hello, it's honor to introduce Dr. Rajvi Mehta. She is one of the first doctors in human IVF in India from ICMR. She is in this field over last 3 decades, and she is treasurer of ACE. She is invited speaker to many conferences, including IFS and HRA. She is convener of IFS SIG on holistic medicine, and we have attended many yoga sessions by Dr. Rajvi. She is academic consultant of Cooper Surgicals India, and she's author of Imagine Egg. So I invite Dr. Rajvi for her excellent talk. Dr. Rajvi.
Has Madam joined, Purva?
With her.
Nandini? I have not seen Madam joining actually. Dr. Pratik is there? I'm sorry for the delay. I mean, I really don't know how it happened. Rajvi Mehta was very much aware of the time, and Pratik also. Dr. Sanjay Shukla is there?
In many workshops, along with her embryological talks, we have attended her anger yoga sessions too.
Ma'am is trying to join.
Okay, again a problem with the link?
And the link is working. Some loop, उनका network शायद slow है, I guess.
Okay, and
She's
please,
trying to join.
I think one of you can call Dr. Pratik Makwana also, so that he's ready for the second talk.
He's joining
Yes.
in 10.
Okay. Doyle is there with us. Doyle, are you there online? Hello, good evening, Dr. Sanjay Shukla.
Good evening, Sam.
Could we have a few words from you? Like we really, during the talk, we'll not be able to talk to you, but Rajvi Mehta has joined, but we will just like to have a, 1 minute thought on this topic from you. The collab between clinicians and embryologists as far as the current 2025 is concerned.
All right, so let me first reveal this to some of the newer people who are in IVF that I'm basically from Indore and now working in Rajasthan. So I represent both the societies.
Yes.
So as you mentioned, there are few people who are here in the panel today. When I started working in this field, I was fortunate enough to start with Dr. Asha Bakshi, And Dr. Gunjan Jain is also here. I have been associated with her also. And as she mentioned, it was like a protocol, a well understood, well, orchestrated protocol that they offer their patients to talk to us. And that makes a lot of difference, because then they come to know the nuances of the embryology from the perspective of a common man. Sometimes the clinicians, they do not have that much time to talk to the patients, but once they come to us, the embryologists, and they get the answers they wanted to know, it makes a whole lot of difference. And your counseling session comes down to little, to some extent, and then they have faith in you, in your team, and even if the result is negative, they are comfortable that whatever is told to us was fair enough. So this dialogue, not just between the couple and the embryologist, but also between the embryologist and clinician, embryologist and the ancillary staff. So, because the couples, they are already under pressure. So they talk to everyone, not just the embryologist, not just the clinician, not just the counselor, but also to the nurses, to the, janitors, to the guards. And if they get similar answer from everywhere, they, get some sort of assurance that, yeah, it's very transparent clinic, and whatever everyone is telling us is true, is genuine, and that makes a difference. So it must be, encouraged. It must be inculcated in the clinic, this sort of trait. And, this leads to the development of the team and the clinic. I think you are mute.
Thank you. Thank you, Dr. Sanjay Shukla, for that deep insight into basically the clinic atmosphere and how it should work. And we have now our first speaker with us, who has been introduced. Dr. Rajvi Mehta, madam, welcome. Good evening. Madam, the floor is all yours. You can share your slides, please. Rajvi ma'am, you can start your talk.
Am I audible? All okay?
Yes,
Yeah.
yes, ma'am. Yes, ma'am. All good. Welcome, madam.
So thank you, SR and the Synergy team for inviting me. And it's an interesting topic to start the session about starting strong essentials of a high-performing IVF lab. And I have highlighted the words high-performing because what I understand by that. So first and foremost, when we talk about performance, a high-performing lab would be that you have good results. And good is a very vague term, because good expectations, aspirations of a patient is 100%, expectations of a clinician maybe X%, expectations of the embryologist are different, aspirations are different, but something which is acceptable. Second thing is the results need to be consistent. And this is something which is very, we are working in the field of biology and nothing is absolutely a straight line. There's always variability. So how do you monitor the consistency over a period of time? And the results is also a vague term. Because what do you mean by results? Results are pregnancies. Results are pregnancy rates. So was it per transfer, per cycle, per patient? So everything is highly variable. So we need to first understand that what we are talking about, results, would depend totally on the denominator. And I often say that IVF is a game of numbers. You can have a lot of cases and change the denominator, the same result can have different meanings. So for a high performance lab, for assessing performance is very critical, and it cannot be something subjective where you feel, okay, we're doing well. Suddenly you get a couple of results positive and we get elated, and suddenly there are a couple of cases which are negative, and it becomes depressed. So we need to be very highly objective with that assessment. So now we come to the crux of the topic is what should be the starting point? What should we consider before we start an IVF lab? And everybody who starts a lab wants to be a high performing lab. All of us who get into the field want good results. Who doesn't want their patients to get pregnant? So a couple of things need to be taken into consideration. One is location. Now, every individual breathes, every cell breathes, every embryo breathes, and the air around makes all the difference. We may have a lot of purification systems, but the location does make a difference. So we talk of two kinds of location. One is location within the entire clinic. And whatever is ideal is not real, because you may want to go to the best of environments, but it should be convenient to patients. So whatever is the location of the clinic is something which you have to accept, but the location of the lab within the clinic, then as I said, everybody breathes. So the air ventilation systems play an important role. The design of the lab, what are the materials to be used in the lab, the layout of the lab. So everything that will contribute to our performance. Equipment, how do you procure that equipment? So somebody can provide us with a list of equipment needed. We can order it, maybe best prices available. But how do we make sure that the equipment that we use is going to give us the result that we aspire for? People. Finally, the lab is made up of people. Equipment, even in the era as and when we have automated ICSI coming in, we will still need people. I think in today's era, we need to be also very clear about the legal requirements. And embryologist is not directly responsible for whatever happens. But if the head of the clinic says that things had happened in the absence of the knowledge of the head of the clinic, the last person handling is always the embryologist. So I think every embryologist needs to be aware. And quality, as I said, biology is not 100%. It is full of variability, and our ability to track when things are going downhill before they have completely reached a disaster stage helps in prevention of maintenance of good performance. And data. Data is not something which is necessary or demanded by law. Data actually tells us how we are performing, because as human beings, we can be very subjective, and I appreciate the subjectivity, but assessments are preferable objectively. So now we go to the first thing is what is an ideal location. An ideal location would be where you have minimal contamination with volatile organic compounds and particulate matter. Now, as I said, you have a clinic which is located at X place, but the air that comes in is from the outside, and that can contribute to VOCs and particulate matter. So if you're staying in a residential area, you would not have high VOCs. VOCs will primarily come in from industries or places where there is organic gases, a hospital premise. So we need to see where does this contamination of VOC and particulate matter come in. If you happen to be in a city or a township or a location which is highly industrialized, these contaminants are going to find their way in. If there are pesticides around, traffic, and all this was realized by some observations many decades ago. One of the earliest reports was an Italian clinic where the clinic moved their location. The staff was same, the patient profile was same, equipment was same, the results drastically went down, and then they realized that the clinic had moved closer to the highway, and this is where the problems had started. Then also what kind of plants are around, what kind of activities are around. And mind you, it's not only the outside air that contributes, it's also the air within the lab or the clinic. So the building material that is used, the furniture in the lab, plastics, planes, are the biggest paint is especially a contributor of volatile organic compounds, adhesives. For example, in a country where the temperatures can go high, and if we have used adhesives, then or glues for the tiling, maybe it's fine in winter, but in summer with the temperatures going high, they can lead to the release of VOCs. Even things like cleaning solutions. Now you may have your employee who is very, very meticulous of cleaning up the lab. And they may feel, oh, the lab, doesn't have good smells. So decides to put air freshener. Now that's going to contribute to VOCs. It's all done in good intent. Or maybe he gets a cleaning solution. So education of these people is very important on what is being used within the lab. anesthetics, and people contribute particulate matter. We constantly shed skin, and this skin would also contribute to the particulate matter. So when we study the particulate matter count, when the lab there is no movement, it is pretty low. Moment there is movement, you have an increase in particulate matter. And that is the reason one is also pretty restrictive of the people coming into the lab. Now, the question is that are we being very, very critical on ourselves? Do VOCs, particulate matter really matter? Or are we just being paranoid and talking to say, let's have the best quality air? And best is, as I say, is an ideal situation. Real situation doesn't give us best all the time. So this is a very, very old study. Maybe many of the embryologists were not even born when this study was reported. It was more of an observation. And what they found was that in the early days, people did a mouse embryo test. So they would have mice zygotes and then see how many of them developed to blastocysts. A simple test. So when the embryo, the fertilized oocytes, the zygotes developed to blastocysts, the culture conditions were fine. And they found that every week the test was being done, and they found there was nearly 100% blastulation rate. But a week later, suddenly it dropped from 100% to just 3 out of 44 zygotes. And this was quite a disaster. And then again, next week it came back. Rather than just being happy to find that the expanded blastocysts have come back to what earlier, these people decided to decipher what exactly happened and why did it go down to this extent. And they found that what had happened during that phase where it went down was they were applying flow tiles. And flow tiled application required adhesives, and these kind of adhesives led to the generation of VOCs. Well, as the levels went down, things came back to normal. But this was a red flag that VOCs could come in any form at any time, and one has to be alert to them. And second is particulate matter. And all of us are now very, very highly aware of the contribution of particulate matter to human health. Every winter, we complain about the high particulate matter count across the country. Now, even in this particular observation, so when one looked at one's data annually, David Boone and they found that there was a drastic reduction in the pregnancy rate. There was a slight reduction in embryo development rate, but the pregnancy rate was very, very low. And they couldn't attribute to anything obvious in the culture system, in the culture condition, in the type of patients or the personnel. And then finally, they realized that there was a lot of construction going around in the area in just the neighboring to the lab, and that the particulate concentrations were very high. And then they found it to be potentially associated with the lower clinical pregnancy rates. And since this time, VOCs and particulate matter are red flags. They are silent killers of embryos because we can't really see them, feel them. If we can smell the VOCs, the levels are extremely high. So these become pretty important. And, rather than, and when you find that the pregnancy rates are dropping, the number of blastocysts are dropping, the first thing to check is air quality. And if you're starting a lab, we need to make sure that we have a well-established air handling unit or an HVAC unit. Now, HVAC system is basically a heating, ventilation, air conditioning system, and none of the IVF labs have natural ventilation. So we are in a closed room. So as it is a closed room, has limited air changes as compared to natural ventilation with this cross ventilation. You may have 50 air changes per hour, which means that 50 times the air has changed in an hour. So if you have good 2 large windows on opposite sides, but an IVF lab is a closed lab. So you have about 8-10 air changes per hour. But remember that what is outside is that's what comes in. We may have filters, but if the outside air is extremely poor quality, then these filters will also get blocked at a point of time. Secondly, we need to know how that air enters into the lab because it will form patterns. So where does it come in? Where does it go out? Where are the in ducts? Where are the out ducts? So all that needs to be known. Where does the air come in from? So the first inlet flow of air, is it coming directly from outside or is it connected to the OT? So ideal situation would be that you have the outside air coming in. Secondly, we do know that when you have air handling units and you have a common air handling unit, what the outside air, how the ducting is. Sometimes the ducting is so huge and it's so massive that even a rat or a bird, anything can get in. So you need to ensure that you have proper filters. So these kind of things, because it's nearly next to impossible to clean them. So again, these will start contributing to the quality of air. The lab itself will contribute. The gases that we use, they would contribute to the VOCs in the incubator. So all in all, it's something which is very, very silent. And if we have good systems in place, then at least we can not be stressed by the external environment. Now, how do you maintain it? It's something which you can't see, which you can't feel. How do you maintain it? So first, we have to ensure where the inlet of the ducting is. Now, imagine that when you have got your IVF center opened, it's nice residential area, small cottages around or bungalows around, good clean air. Over a period of time, maybe a big mall comes in, maybe a restaurant comes in, and the restaurant has an exhaust which is out, and your inlet is taking in the air pushed out by the exhaust. Now, all that is going to enter into the lab. So we need to be constantly aware of where the inlet is. Then the ducting, as I mentioned, has to be properly maintained. Make sure one has a lot of filtration units. It need not be a HEPA filtration units right at the start. It becomes very, very expensive to maintain. So they are like pre-filters, preventing any kind of large stuff coming in. And remember, when there is a filter, it needs to be replaced depending on the external quality of air. Because if the filters get blocked, then the pressure becomes low. And as you enhance the pressure, these stuff which has accumulated on the filter will be pushing in, or the pressure of air coming into the room will lower down. So it's best to have a proper maintenance system for the air in the unit. So when you have, now one is that, second is you have a filter which is separately installed, is kept in the room. So it's a standalone filter. And when one looks at data over various studies done in the initial stages, now we need to have filters. It was really found that moment you kept some kind of filters, there was a reduction in particulate count, and it showed an improvement in the outcomes, be it the blastocyst formation rate or the pregnancy rates. So basically, there was an improvement with filters. And today, the message goes that we need to ensure that we have standalone filters and make sure that they are maintained, filters replaced as and when required. I would not stipulate a time, because if the outside air is good, the good pre-filtering system is there, and if they're not getting blocked, you don't have to be time bound to change it. So according to me, the best thing to do is measure the quality of air regularly on a regular basis. And if the levels are within limits, if the levels are fine and your biological outcomes are fine, you need not worry about it. Now we come to the second phase. So you have decided on a location, the clinic, the lab place is finalized, and then you go ahead to start the construction. You have taken care of the ducting, what all will be required. Now, what should be the walls kind of thing? So it's better, like I said, if you put in tiles, you're going to have problems, and it should be something which can be easily cleaned and maintained. You don't want it directly touching, it's best to have your lab slightly inside, because if it is at the external with the heavy monsoons, with the humidity, especially in most places of the coastal area where we have heavy monsoons, then that can again create issues. Modular labs are in, but then the cost is an issue. Even when you select paints, one has to be very careful that they should be low VOC. Even if paint is said to be low VOC, there is always some amount. And the best thing to do is, after a lab has been constructed, give it time to off gas, which means that just leave it alone. Let whatever has to be released from all the equipment and the construction that has been done is released, and you just give it time for it to get off gas. Then we come to the flooring. Now, what kind of flooring should it be? It should be something, again, we don't want to put something which would generate VOCs, because it can happen at any point of time. Recommended by Mortimer, who is quite an authority on lab setups and quality assurance, is vinyl sheets. But remember that in your cryostorage area, where there will always be spillage of liquid nitrogen, vinyl is not to be used. Now, when you plan the lab, you wherever it is located, one has to plan it in such a manner, the internal design, how you're going to get the equipment in. For example, if you have kept, a small door to come in because you don't want contamination to occur, and you have an empty room and a small room just enough for a person to walk in, then make sure how's your equipment going to come in. So you'll have your large workstations coming in, you'll have your large incubators coming in. So you don't want to land up, have a very nicely designed lab, and then you find, you have to break the walls to bring them in because your lab will not have any windows to pull it up. So keep that in mind. Also, there should be how are you going to move in and out of the lab. And by you, I mean the personnel, I mean the material, patient material, and even the disposables, etc., that we use. So we don't want it directly coming in from the delivery person directly into the lab. Also, we need to design in such a manner that there is no chance of an accident to occur. Two people walking in, they bang into each other. So, these are small things, but when it happens, it's a disaster. You don't want the door of the incubator of the workstation facing the door of the lab. Because if by any chance somebody opens it, you will, even if you have air curtains, it's better to keep it away. You don't want your micromanipulators close anywhere close to centrifuge. You want to make sure that the incubator door opens as per your handedness. So if you are left-handed and the incubator door has to be opened in this manner, you will find yourself struggling. So small things which can risk accidents. And something. Second thing is when we have gas cylinders, we don't want to take the gas cylinders inside the IVF lab, but make sure they're very close to the lab. One story that I heard was that there was gas cylinders. The lab was on the 3rd floor. It was a nice big hospital. And the people who designed the hospital and the management decided to have one particular place for the cylinders, which was on the ground floor, where it would be delivered. Now, the problem is the lab is on the 2nd or the 3rd floor, and they insisted that the cylinders remain down because a special area was created for it. Now you can imagine the plight of the embryologist, because first and foremost, you can't keep checking it. Secondly, what will be the pressure? What if the pressure becomes low? So, something which has been designed, please take into consideration the people who are experienced embryologists and not just the architects, because they have another perspective. The embryologists or the people working in the IVF lab have a different perspective. So something like this has to be borne in mind. Now, I talked about movement of the staff, movement of people, movement of personnel. So if this is the entire design of the lab and you have the personnel moving in, so the lady, for example, goes into the changing room, changes, moves out, then goes into the ante rooms, and then starts entering the embryology lab. So there is an inlet and outlet. Moment they wash up, they'll go through there and directly enter the embryology lab. So the thing is that we talk about contamination. Remember that we change into scrubs, but as far as the lab is concerned, we have to be very careful that we are very careful about changing our footwear, and it is used only in the lab. So if we are very particular about that, we'll not be getting outside material in. Sometimes people say that in American countries, in certain European countries, people just go in with street clothes. But remember, our temperatures are different. Our humidity levels are different. So let us not, the roads outside are different. However clean it may be, the temperatures make sure that microbial contamination is a high risk. So we need to be very cautious and not just imitate, but principally make sure that we contribute minimally to the change in the lab environment. Even the material, you don't want it to come directly into the lab. So you have a separate area for storage far away from the lab, in that sense, where your cartons, etc. are stored. And then through a lobby, they come in through the andrology lab. So basically, you want your liquid nitrogen source directly going in. So it should be so well planned that it has minimal movement, but still a safe distance. So once the lab has been set up, we've got the location, we've planned it, we've designed it, then we decide on the equipment. And the checklist is very clear on the basic equipment. Incubators plus glass cylinders. The lab cannot function without any of these. Microscopes. You will have the basic compound microscope for semen analysis and processing. You will have your the microscope for visualizing the gametes. And most important, you'll have your inverted microscope with the micro manipulators for all the visualization of the morphology of the oocytes and embryos, and absolutely essential for ICSI. Workstations for a clean work environment, maintenance of temperature. Centrifuge, well, even if you have moved to microfluidics completely, I would say you still need to keep a centrifuge in place, even in the culture room, because if for some reason you don't have your chips coming in, you will have to go for density gradient. So pick up a backup power supply. We don't really have problems with electricity now in many parts of the country, but you never know. And it's Murphy's laws. When things have to go wrong, they will, and possibly when you least expect it. So a backup power supply. Now the problem is that the people who are used to power issues, they know how to maintain the backup power supply. They know how to maintain the UPS system. But for people who have never used it, they may not even be familiar of how to maintain. So there, it's better to make sure that your power supply, the batteries are all charged. Cryo cans are not really within the lab because the place where it's kept requires good ventilation. The cryo cans are not sealed. Liquid nitrogen constantly comes to the environment. And if it's a closed room with poor ventilation, it will displace oxygen and can be risky to the life of an individual going into a room. There have been 1 or 2 deaths reported because of low level of oxygens where many cryo cans were placed. So something to be aware of, because when you start a clinic, your objective is not to serve a few people, but to expand. Nobody wants to say, I will start an IVF lab and do only 10 cycles a month. You may start with 10 cycles a month, but your objective is to grow. So one has to be prepared for that. So moving on, I'm not going to describe all the equipment, especially, we have standard company, standard things, except for the incubators. I will talk a little bit about it. So, one has to sort of plan when you get your equipment that, okay, if you, how many cycles do you intend to grow in that place? And you have at least, you don't buy all the incubators, but you should have space to put all those benchtops incubators that are going to get in. Also, the power supply and plug points, the location, supposing it cannot be that you need a long extension board. So these things seem trivial, but suddenly you have a new equipment and then you need extension. And then you feel there's a power load. So things should be done. Every equipment has to be validated and calibrated. Calibration is a must. What it reads should be externally validated with, again, a calibrated instrument, whether you're looking at temperature or CO2 levels, and annual maintenance contracts. So when we started ages ago, there were very few IVF labs, and the manufacturers or the company guys, the engineers were always available 24/7, literally. But today, with so many labs, it's practically impossible for them to serve. So it's best to see that the equipment is well maintained. Power supply, I've already spoken, and gas, I have already spoken about it. So I think the heart and soul of the IVF lab is the incubator. So we have the standard box type incubators, very sturdy. Definitely, they maintain the temperature, but once opened, there is a drop in temperature and there is a drop in CO2 levels leading to an increase in pH. So just to give you an example, that if you open a box type incubator for just 5 seconds, there is a drop of temperature in the dish within that 5 seconds, and it takes it nearly 25 to 30 minutes to come back to normal. So you can see that the temperature in the dish at 37 degrees after a 5 seconds opening of the box of the incubator, it drops down, but to come back to normal, it takes nearly 25 to 30 minutes. So the question is that if sometimes we feel, I don't do many cases, I just do batch IVF. So I do about 4, even if you're doing 4 to 5 cases a day at a time, imagine the number of times you're going to open the incubator, and every time a 5-10 seconds drop, 10 seconds open of the incubator will bring such a drastic drop in temperature. And imagine the cases which have already been there in the incubator, but they are constantly exposed to lower temperatures. And again, the problem with the box type incubator would be that the temperatures differ in the front and the back of the incubator at the different shells. And there is, even if it is minor, there is a difference. And add on with the opening and closing of the door, it enhances. And that's the reason we moved on to a benchtop incubator, which is, recovery is much faster. It is sturdy enough, but, considering the recovery times of a conventional incubator takes about 30 minutes. I just talked about 25 minutes. But in the study, they found about 30 minutes for the temperature to come back to what it was. But for a benchtop, naturally, the internal area is so small that it comes back in 5 minutes. Even oxygen, it takes half the time or less than half the time to come back. And that's why most clinics have shifted for embryo culture to benchtop incubators. Now, the fact is, yes, the the temperature changes. Does it really matter? Or, everything has to be also shown the impact it has on the biological aspect. So here you can see that when they used a benchtop, primarily I'm trying to say where the recovery rates were of temperature were faster. They had embryo formation rate, early stage, 40%, 15% blastocyst, is a very old study. But the conventional incubators, it was much lesser. So clearly the message went across that recovery rates do impact outcomes. Now, what is the impact of temperature on blastocyst development rate? So this is a much recent study. So if you consider an ideal temperature of 36.4 to 36.9, when the temperatures went lower, and remember our rooms are air conditioned, you open the box top incubator, or even if you open the bench top incubator, temperature is going to immediately lower down. I showed a 5-second time. You can see that from an ideal temperature, giving a 41% blastocyst development rate, it went down to 33%. So we are going to get less number of blastocysts just because the temperature has dropped down. Again, if you look at the implantation rate, that also significantly drops down. And naturally, you will also find a drop in the live birth rate. So the temperature of the incubator is fine. There's nothing wrong with the incubator. There's nothing wrong with the lab. But just that because we don't have sufficient incubators, or we are opening the lid or the doors of the incubator frequently, there is a consistent temperature drop, which can affect the performance of the lab. I'm not going into the other equipment. I'm doing more with maintenance, but I really wanted to highlight about all the silent features. A silent drop in temperature can impact. Now, the other important aspect is the people. It is the people who make the lab, and in the lab, it is the embryologist which plays the role. Now, as per the law, an embryologist should be a PhD or a master's in clinical embryology with 1 year laboratory experience, or an MBBS, MSc with 1 year training, etc. Now, it doesn't mean that people who don't have the experience, they can be junior embryologists. It is with that qualification and experience, the lab can have them as they need them to register the clinic. But remember that just having a PhD educational qualification is not enough. Much more is expected of an embryologist than this knowledge. So whilst one is doing an MCE, the amount of exposure one has to the practical aspects can be quite limited. Also, to a real scenarios can be still limited. So very few university setups may give you the exposure to real life ART labs and the ups and downs that go with it. So what is required from a clinical embryologist? A lot of skills are required. So, on their own, people have sort of graded them. So doing a semen analysis, semen processing, cryopreservation, preparation of dishes is something for a junior. It's something for a trainee. It's something very simple. Then comes screening for the oocytes, handling, and midway junior embryologist. Conventional IVF, in a lot of cases, it's totally forgotten. Although it is a pretty simple technique, considering requiring less skills, but for reasons which is a topic of discussion in any other forum. So culture is okay. Then denudation, vitrification, yes, embryologist is, budding embryologist is happy to do that. And the highlight or the goal seems to be able to do ICSI to do ICSI. So, the most of the frustrations of new embryologists would be, I'm not allowed to do ICSI. If you have just graduated, remember, you are need lots of experience, not just demanded by the law or the agencies, because the limitations of skill can compromise the performance of the lab and the potential of the couple to get pregnant. So what is the expectation from the clinical embryologist? Skill, yes, we listed all those things and one can acquire that. But beyond that, beyond skills, beyond the ability to have a mastery of ICSI, you still need to maintain the lab. You may do a great ICSI, quick ICSI, but what if the lab is not maintained? What if the parameters of air, etc., I've talked about are not maintained? How do you ensure quality? In the ART lab, we work with nearly 200 plus variables. And the biggest variable is the patient material, which is something which is not in the hands of the embryologist at all. So at least what is in our hands has to be maintained, and that becomes the job of the embryologist. So, any small deviation, we should be able to get it. Ability to troubleshoot. Things can go wrong and will go wrong. It's not anywhere life is going to be a smooth process. There will be hiccups. So we should have the ability to quickly troubleshoot and take decisions. Inventory. So why should I bother? I'm not there as a commerce person. I mean, a purchase person can tell you, okay, the medium is going to come, but it has not arrived. It will come after 2 days. Oh, it's okay, it will come tomorrow morning. It doesn't work for us. We need it. Oh, the dishes were to come. There was a problem in delivery. We had placed the order 2 months ago. They've got delayed. They'll come a week later. So we need to be in control, even if it is not our job per se. Documentation. It is the documentation and the data which guides us. Our experience guides us, our seniors guide us, but I think it's the data and documentation of the data, which is, and analyzing that, which is actually going to help us improve the performance of a lab. So how do you assess? I started talking about good quality and consistency. How do you assess one's performance? Is it the number of pregnancies? Is it the percentage of pregnancies? And I talked again that, rate is so variable. What is the denominator? Per transfer, per stimulation cycle, cumulative per patient. So each of these rates, I'm going to look at the rates of donors or the young patients, old patients, everything together. So there are so many variables, and with all that, you will never come to a conclusion of how the lab is performing. So we need certain assessment tools. So it's the patients, the biggest variable, people. Yes, new personnel or we ourselves can have ups and downs. Of course, with more and more experience, the variability becomes much lower in performance, equipment, and the processes. So how do you assess performance? And you have to track various parameters over a period of time. So, say month of January, what was the number of mature oocytes, number of oocytes that degenerated or got damaged during ICSI, fertilization rate, cleavage rates. So each month, and this tells us over a period, it takes into consideration the variability of the patient profile that's coming in. Even the patient profile can be cut down to, say, donors or separate them on terms of ages. But even if you take the entire profile except donors, you have certain parameters and standards have been laid. So if you want to make sure your lab is performing well, you have to go by the international standards, such as, and the Vienna consensus tells us about the lab performance parameters, while the Alpha consensus tells us about the cryopreservation consensus. So there are two aspects to this. One is to show that you are competent to independently do these procedures, or be an embryologist and your lab is performing well more than the individual. And second is a benchmark, so your aspirations can be very high. So these are set, and the benchmarks can be done by individual labs or clinics on their own. So you can have, say, ICSI damage rate. If you have less than 10%, that's acceptable, but you would strive for much lower damage rates. We talk about fertilization rates. Well, ICSI, at least more than 65%, but you can set higher benchmark. IVF, conventional, at least 60%, because and we are talking over a period of time, day 3 cleavage rate of 45%, and these were set by the Vienna consensus. These can also be modified by the lab, by the team. So if you meet your competency levels, you can raise the bar for your organization. For cryopreservation, you have that the alpha consensus, which says that at least less than, there should be oocyte survival, sorry, it is more than 70%, and benchmark survival should be more than 85%. The blastocyst survival, more than 80%, and even the benchmark can be 95%. So with vitrification, we know that survival rates are high, and it is expected. So your vitrification system is working well if you manage these standards. Now, how do you measure it? I talked about monitoring every month. So you have created your competency level, you have created your benchmark. So that becomes your mean, and that becomes 1. And then anything your results. So supposing you say you want a fertilization rate of 60%, that becomes 1. And then you plot the standard deviation over the period of time. So, because it's going to vary over weeks, over months, you can't expect, it to be constant. But anything above or below 2 standard deviation, you become alert. So if it is the ICSI damage rate, if it goes below above 2 standard deviation, it is a red flag. On the other hand, if the fertilization rate goes below 2 standard deviation, then again, we have to start getting alert. Something's going wrong. So don't wait till, you have poor pregnancy rate results 2 weeks later. So one has to be watching the variation in the standard deviation. So to conclude, I will say that a high-performing IVF lab should be, yes, a well-equipped lab, but more important is a well-maintained lab and well-maintained equipment. Every equipment, everything about maintenance should have the standard operating protocols, and these protocols have to be followed. So they're not to be a manual which is kept in the shelf because the protocol demands it, but you are following it. And any changes that are being done can be done, but with consensus and with modification. Skilled embryologists, it's a must. It's also important to have a healthy work environment, because when you're working with so many things, so many cases, if there is a lot of pressure, mistakes are bound to happen. So if there is not a situation where the team of embryologists works together, then people are in a pleasanter environment. There's less chance of stress, because stress can lead to errors. Also, the embryologists need to be alert. They need to have the patience. So whatever processes are there, you cannot take shortcuts on them. You need to be very vigilant, because that's where you're going to observe any kind of often it's the intuition which, so rather this patient didn't get pregnant and the embryologist believes, that it's a unsaid rule that the needle of suspicion gently goes towards the embryologist. Embryologist will be mumbling, saying, "Oh, it is." In this, it's a very healthy environment where you don't just see that you're improving the it does do fast, but if we sit other cases done, you have to see that what was done was the best possible at that point of time. But could anything have been done differently? So that gives us an idea. It looked like this to start with. It could be, yes, the eggs were exposed to higher progesterone. So, it's sort of government. I feel we should not be satisfied if we meet. We should always try to analyze failed cases, and that can be possible if you have a healthy work environment and you have a good team and sufficient staff. And I think it is also for the embryologist or for the entire team to maintain calmness in times of crisis, because this field can lead to crisis. It could be something, and when you don't have the experience for it, one can get into a panic mode. So just being calm, okay, this has happened. So automatically one starts, rather than defense, tries to see what is the best that can be done. So I think it is possible to maintain a high performance lab, but it needs support from all fronts, from the setting up of the lab to the maintenance and team support. So I hope I have covered all that can be included for this very vast topic.
Indeed, very vast. Chairperson's comments.
Yes.
I think Dr.
That
Gupta is
was
here. Yes.
indeed well planned and very crisp points that we all need to keep in mind during our practice, especially when we are handling. It's just not one person's effort, it's a teamwork. And everywhere, whether it's a clinician or it's an embryologist or it's just a technician, each point has to be catered to. Now, ma'am, just one thing I would want to ask, this is about the disposables that we use in the lab. Any disposables, or do we have any particular criteria of selecting those disposables that are to be used?
See, disposables are the ones again which generate a lot of VOCs, and plastic are, we are dreading plastics now. Today there's a report of plastics in the human ovaries. So we are directly culturing plastic dishes. So I think that the quality of the disposables is important. Also, maybe according to me, it's a good idea to have your disposables come a period in time, like you prefer media fresh, let the disposables come and let them be off gassed. So plastics, and we had a lot of varieties of disposables coming in. So we make sure that they are tested. Again, we can't test the composition, but at least let them be tested to see, the routine tissue culture, but also embryo culture. So if the mice embryos are growing, then we presume that at least the humans would maintain. So many of the things it's difficult to analyze the substance, like you can't really analyze the air, you can't really. So, but if you see that the system is working well. So like in the earlier days, they would do a zygote culture and do it is not practically possible. Then okay, the system is working. So if the media and the disposables have been tested with mice embryo growing well, then we can be sufficiently relaxed that things are in place. So it's not just any dish that can do.
Okay, right, ma'am. Thank you.
Dr. Nibha is our chairperson. She was about to join, but I think she's not able to join right now. She's in the US. So we will proceed with, I think, thank you so much, Rajvi ma'am. I admit I was a little connected here and there, but whatever I could gather from your talks, it was very, very lucid. And you had placed a lot of importance on the benchtop incubators. Giving way from box to this thing. And you also stressed upon a calm environment, which is so, so important. Thank you so much, ma'am. And we are really, really deeply grateful to you and to Manisha, who could, get you to us. And we are so fortunate. We are just jostling, to listen to Rajvi Mehta madam's lectures in the conferences. Here we are sitting face to face with you across the laptop. And it's true luxury to listen to you, ma'am, from the comfort of home. Thank you so much, ma'am.
Thank you.
And now I think I will introduce our two dignitaries who have joined. We have our guests of honor, Dr. Abha Jain, ma'am. Dr. Abha Jain is President Bhopal Ops Gynae Society. She's taken over this year as the president. She is also Director and Chief Gynecologist of Lifeline Hospital and IVF Center in Bhopal. She was one of the pioneers of starting fertility services in Bhopal. She has also held various administrative society posts in the society. She is an alumnus of GMC Bhopal with a lot of years of experience in practice. And she's taken training in Australia. She started her IVF center in 2010. And Madam is with us. Madam, would you like to speak a few words to us? Madam, yeah.
Hello, Monica.
Hello, ma'am.
Can you hear?
Yes, ma'am. Yes, ma'am.
That this was a fantastic talk, and she has covered each and every aspect very clearly, and we got the message that we have to look after many things when we set the lab. Even the exhaust from our neighbor building or the neighboring person can affect our results. That is also very, very important point. Sometimes we forget it. And we also suffered because of our neighbors' exhaust. So I think this was a very, very, very nice talk. Thank you.
Thank you. Thank you so much, Abha ma'am. I know you're in the middle of busy OPD, but you could join. Thank you so much. And we have got Vibha Mohan madam also with us. So
Hi,
madam,
Monica.
thank you so much for joining all the way from your vacation in the US. And
Right.
would you like to
So
comment, madam?
hello to the whole team, and thank you, Monica, for having me here. I was finding difficulty joining, so I think for a moment I could join. So say hello to all of you, and just heard Dr. Abha that the talk was excellent, and your topic which you chose, it's very important for the best result of IVF, which we all are trying to do. So all the best to you and your team and for this event. That's all I can say, because weather is not very good. Connectivity is very poor today, this morning. So anyway, all the
Thank you
best
so much,
and
Vibha ma'am.
happy
And we
joining.
wish you all the best for your forthcoming elections in Foxy for chairpersonship of Foxy Breast Committee. All the best, madam, from Team Synergy.
Thank you so much, Monica. Thank you.
Thank you, ma'am. And now we welcome Dr. Nitish Modia, another great friend of ours, myself and Randir. We've had many a times breakfast, coffee trips together. So Nitish, once again, we meet at the Synergy Academic Club. We are welcome. Sir is the expert member of National Assisted Reproduction and Surrogacy Board. We know what a change he has brought about in the scenario of corporate IVF in India. Amongst the many awards he has won, one of the most prestigious one is Budding Embryologist of the Year, gold medal by the ET Health World National Fertility Awards in 2019. He is leading a team of 160 plus embryologists. He's set up a educational program of excellence. He holds a strong background in management and SOP-driven systems. We know his passion for improvising on the already existing techniques. He has trained several embryologists and andrologists till now, special interest in AI, new technology innovations, quality management systems, and digitalization. He's brought in exceptional technological advancement in Indra IVF network with the help of electronic witnessing, automated alarms, cloud monitoring systems, and QMS dashboards. And whenever we have any doubt in ART law, the first person we try to contact is Mr. Nitish Modia.
Thank you very much, Monica madam. Good evening and a very warm welcome to all of you. I think it's a great selection of the topic, a high-performing IVF laboratory. And I would just like to summarize a few points which was already covered by Dr. Rajvi, and also just add a few things from my side. I think a high-performing IVF laboratory is the beating heart of any fertility clinic. Excellence begins with rigorous quality management systems, which ensures traceability, standard operating procedures, and continuous monitoring. Air quality control is paramount, and clean air standards with HEPA filter, VOC-free environment protect the sensitive nature of the gametes and the embryos. The lab must be designed for workflow efficiency, separating the zones of embryology, andrology, cryopreservation, and ICSI areas to avoid cross-contamination and temperature fluctuations. Technological precision is another cornerstone. Having the right kind of technology and the equipment in the lab are necessary. Equal critical is the human element. A skilled embryology team with ongoing training and performance audits supported by a culture of ethical integrity and emotional sensitivity. Regular participation in external quality audit programs. There are few running in India like QI and NABH, and there is RTEC also available from Australia. Ensures benchmarking against the global standards, while robust data analytics and the KPIs such as fertilization, blastocyst conversion, implantation rate, cancellation rate will help drive outcome. In essence, a high performing IVF laboratory just don't create life, it upholds the highest standard of science, care, and hope. Just to add a few things to Dr. Rajvi's presentation in terms of KPIs, we also monitor, other than the normal KPIs, the cancellation rates. So stimulation start to OPO cancellation rate gives us an indication of how well the clinical part is being driven. And from OPU to ET cancellation rate, it gives us a rough idea of how the lab is performing. So these two parameters are also important to monitor, which is the cancellation rate. She has pointed out very well about the incubators, especially the benchtop incubators. And typically what I have seen is when we are doing a sibling culture in a normal incubator, which is a bench type incubator versus a time lapse, and because we were not opening time lapse, we have seen that the blastocyst conversion rates in the time lapse incubator were 8 to 9% higher than the benchtop incubator. So opening the incubators and closing the incubators is one of the key challenges, and you should have sufficient number of benchtop incubators in the lab to handle the load. Thank you.
Thank you, Dr. Nitish, for the inputs. And we always look forward to listening from you because your thought process is very, very innovative, very, ahead many years than what normal people can think. I think you take a leap forward almost by a decade. Thank you so much for joining, Dr. Nitish. And Purva, can we please proceed with talk number 2?
Yes, ma'am. So after the setup of the IVF lab, now moving to our session 2, that is Level Up Innovation, Reshaping the IVF Lab. To chair the session, I call upon Dr. Sanjay Shukla sir, Dr. Namita Kotia ma'am, and Dr. Anuradha Tibarwal ma'am. Dr. Sanjay Shukla sir is a very senior consultant clinical embryologist in Jaipur, working with Asta Ferticare, Diva IVF Center, Shivani Fertility and IVF Center. Sir is past president ACE. He has also held a former post of former adjunct professor clinical embryology in Department of Reproductive Medicine and Surgery, Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. We welcome you, sir.
Thank you very much.
Dr. Namita Kotia ma'am is not able to join, ma'am. So Dr. Anuradha ma'am and Dr.
Yes, good evening, ma'am.
Good evening, ma'am.
Yes,
Madam is presently the IFS Secretary of Chhattisgarh chapter. She is consultant reproductive medicine in MMR Hospital IVF Center, Raipur, Chhattisgarh. The vast obstetric and gynecology experience of more than 2 decades. She is trained in various ART procedures and a very trained endoscopic surgeon. We welcome you, ma'am, to chair the session.
Thank you so much.
And now I request chairperson to introduce our speaker, Dr. Pratik Makwana, sir.
Dr. Anuradha, may I request you
Yes,
to
sir.
introduce?
Yeah. Most welcome, sir. He is the director and consultant in Vasundhara Hospital and IVF Center, Jodhpur, Jaipur, Lucknow. He's a member of WHO FITS and ISRE Young Ambassador 2022. Congratulations, sir. And authored so many books in IVF ART, multiple papers and posters in national and international conference, and top 20 healthcare communicator award by IHW Council, NITI, Arogya and National Health Authority. Fertivision 2021 Best Debater. Fertivision, so many awards in his basket. He is a very good speaker and very experienced person. So let us listen from him. Most welcome, sir. Most welcome.
Thank you for the kind introduction. I will just share my slides once. Yeah, are the slides visible?
Yes, we can see.
Perfect. All right. So we have already had a talk and discussing how to build an embryology lab and how to build an IVF unit. All of these things are already done. Now we'll move on to, once you have an IVF lab, how do you future-proof it and how do you take it to the next level, considering all the technology that is now available to you and will be available in the future? So the field of embryology and the field of IVF has been evolving very rapidly. It's a very young field compared to a lot of other subjects. But say 45 years back in 1978, from the birth of Louis Brown to the second IVF baby from India, culture systems have improved. techniques have improved. In 1993, ICSI was established as a robust technique. Manual cryopreservation improved to vitrification. Time-lapse imaging is now a very big thing, and it came back almost 15 years back. PGT has been a long-standing candidate. Add-on, maybe good, maybe not, we'll see. But now the innovation has started to drop in with automation and artificial intelligence. In this part of the time, automation and AI are the backbone of whatever innovations that come in the future. That is what we are looking at, and that is what we'll be discussing. So the traditional roles of embryology has been very nicely already done in the previous talk, from gamete handling, fertilization, technical expertise to scientific expertise, focusing on research, focusing on more on teaching students, lab quality management. Everything has been already done. So I will completely skip this slide. But there are some existing challenges right now in the field of embryology. One of them is, of course, the subjective embryo. Every embryologist has a different way of looking at embryo. How I see an embryo would be completely different, or might have variations from how someone else might look at the same embryo. There will be minor variations in the grades. Granted, after a certain experience, the variations decrease, but now we have a lot of young embryologists also in the mix. There are studies on how IVF practice has led to burnouts, has led to embryologists and IVF centers not being able to function properly due to understaffing or multiple reasons. There is a limited accessibility, especially in areas where it's difficult to reach in, remote areas, because while embryologists, there's an influx, there's still a lack of trained embryologists. And of course, it's very much an open that India as a whole is currently not at its peak research, as a peak research institute as a whole. So these are some things that we need to address. And one of the reasons for that could be that we focus too much on just treating and not towards the academics. Both are important. Treating, of course, is more important, but research holds just as much value. So how do we make sure that we have enough time to do academics also? It's by using the technologies that are now available to us and reducing the time that we are already doing in repetitive tasks. So of course, now AI and automation has become a really big thing, from embryo grading to choosing sperms to robotic ICSIs. We recently saw a baby born out of a robotic ICSI cycle. We need more data analysis softwares, which there are now available, although I'm not sure how many of us actually use it. In some centers, of course, major centers, corporate centers, they are incorporating those softwares, but standalone centers maybe not. What all of this does is, when we have softwares to do most of the work for us, we have enough time left. We have enough time to extract the data, to see where we are going wrong, to see what we are doing right. The image you see on the right is of Aura. It's a lab. The first image is a concept image of the lab. It's a completely automated lab. However, and everybody, when the first image, when the concept image was there, everybody thought it's not possible, it won't happen. But what you see in the second image is a live example. One of the labs in Mexico have already installed this and they have started using it. So a completely automated IVF lab is no longer a concept, it's a reality. Let's look at the most basic thing AI softwares have been developed for: embryo analysis and oocyte analysis. And time-lapse systems have been trying to incorporate it. Let's say, for example, EmbryoScope back then used to have KIDScore, but now they have also upgraded to IDAScore. Now, what has happened is every other incubator with this technology has their own way of giving a score to the embryo or to the egg. Chloe is a software which can be incorporated across any incubator, any time-lapse incubator, and it sort of standardizes the practice because now it has annotations which will be similar across all the incubators that have sort of are using the software. So now look at the workflow. How has it been different? First, if you had an embryoscope and if you were, say, using the scoring system, you would have to manually annotate it. You will have to manually update it in the electronic records that you have, or the manual records, whatever you use. Chloe annotates it automatically. The embryologist can check and make any corrections if required. If not, they can go ahead with it. And it's already updated on the softwares. The patient data is now already updated. The embryo scoring is already updated, what is the score, what is the potential of the embryo to become a blastocyst, or even the implantation potential, which is still a little shaky, but the tool exists. So the time has now reduced. Granted, these softwares are a little expensive, but there are now labs also making their own softwares, making their own AI softwares. And the question again comes, where's the standardization? I think standardization should not be an excuse to not use technology. You should standardize it for your lab first and then figure out from over there. For people who don't have time-lapse systems, because granted the systems are really expensive, it's a very big investment. And for labs, it doesn't make sense for every single lab. So then there are a lot of softwares. Violet is one of them. Magenta is another one. I'll discuss both of them. Other than then, Stock 2.0 has existed for some time. Life Whisperer has existed for some time. These are image-based softwares. So you take an image and you upload it, and they will score it for you. It works with, so if you have a benchtop, if you have a box incubator, these softwares will really help you. Now, Violet, what it does is, it tracks the potential of an egg which you want to freeze. So what will be the potential when you warm the egg? What will be its developmental potential? How will it become a blastocyst? Will it become a blastocyst? What's the score? What's the percentage? Everything is mentioned in the software. You can even take a look at the first image. What are the chances of it becoming a blastocyst? How many of the eggs can become a blastocyst? Even live birth. The data still on live birth is still shaky because there are a lot of factors which come into play. But as an embryologist, the first thing that you should be focusing on is what you get out from these reports. It's the chances of growth of the same egg once you thaw it. And they have a database of over 150,000 eggs, and it's only increasing. The last slide that you see is essentially a patient information report. So you can actually counsel patients better. Similarly, this is the other software. This is not for egg freezing. Violet was for egg freezing. This is for fresh cycles. So it will do the same exact things for the eggs, which are supposed to be inseminated the same day, which is the chunk of our patients. Again, it has the same reports, developmental, what is the percentage of it becoming a blastocyst, what is the score of the oocyte. And with human eye, we look at 4 or 5 data points. Chloe, the software that we discussed, it looks at millions of data points, which the human eye cannot even see in the embryo or in the egg. So there is a certain upside of using these softwares, because whatever you see or whatever you cannot see are the points that are covered by these algorithms. Now, looking at the Andrology Lab, not much has changed since the WHO guidelines or any other scoring that you use for your semen analysis. There's another one which exists, which completely removes morphology. It's called total motile sperm count. So no matter which criteria you use, the scoring hasn't changed at all in the last so many years. It is exactly the same. There's not much, there's no development. But now with SID, Automated semen analysis, I think everybody is aware of. We have devices like MES, LensHook. I have no association with any of the companies, so I'm not promoting their device or their software. I'm just mentioning all of them as they exist. These devices exist. CASA systems have existed. They have had their pitfalls, but they definitely do give you more information when it comes to looking at the sperm. It's not just morphology, motility, but also the quality of motility, the path they take from A to B, a lot of things. So now what SID does is, what I really like about this SID software is it's a single sperm selection software, and it works while you're doing ICSI. This is probably one of the only softwares which help you during your ICSIs, not after, not to look at images, not to see the development of the embryos. Everything comes after you have done the insemination. It helps you during ICSI. What it does is, it's the software you will install in your computer, which is attached to the ICSI machine. And while you're looking at the sperms, the software will actively mark out sperms that you should pick for insemination, so that you can have the chance of picking the best sperm, not just based on morphology, although morphology is still a big criteria for these softwares. And if you look at the study that was done, the day 5 blastocyst rate with an experienced embryologist using SID was way higher than not using SID. So sperm selection during ICSI, which is one of the most important steps, it finally has something which can be used, which can be leveraged for better embryos, better blastocysts, and hopefully better implantation and live birth rates. There was a very recent report that automated robotic ICSIs finally had a live birth. And it's true, this was a study that was done by Santiago Mune and his team. They first tried it on multiple models before going to donor human oocytes. They tried it on mouse, they tried it on hamster, rabbit oocytes, and discarded human oocytes. Table 6 is what we need to see. A manual control and an automated ICSI. There were blastocysts that were almost within the same range of the 30 to 50%. Out of 14 oocytes, they got 8 blastocysts out of the automated ICSI. Out of manual ICSIs, they got 10 out of 18 oocytes. But if you look at the blastocyst transferred within 2 patients and the number of pregnancies, granted that the data was a little less, which they also agree with, which they also mention, but we have had success now with automated ICSIs. Now, a lot of embryologists are often against these technologies, thinking that they will be replaced. They will not be replaced. No, the critical thinking, the human involvement will never go. The roles will evolve. And as embryologists, as IVF specialists, we have to evolve with the roles. If we don't, we certainly will be left behind, not because of an AI software, but because of the next human who learns those AI softwares. Now, looking at the new innovations in the previous year has been really good for IVF. There have been studies using stem cells and ovarian support cells to actually grow granulosa-like cells and support in vitro maturation. This is a very big step. Once it becomes usable across the board globally, it could really change how we use in vitro maturation for oocytes. And essentially in this study, if you go to this company's website, you can see all the studies that they've done. Gamito is the name. You can go and check them out. So in this particular study, what they did was, with the overexpression of various transcription factors, they were able to grow granulosa-like cells, which of course help in the development of the oocyte, in the maturation of the oocytes. They have multiple studies. One is also published in Human Reproduction. You can go and check it out. Gavi is a semi-automated vitrification device. It has existed for some time. Now, Gavi claims that, of course, their results are better, but this has now become a little outdated, but it still exists. Semi-automated vitrification has existed, and now we are moving to completely automated vitrification systems as well. However, with manual vitrification, the one we currently do, it consistently performed either equal to or better than Gavi. So Gavi was left a little behind. It still exists. It's been there for quite some time now, for quite a few years. I think more than 5 years it has existed for now. But now we have moved from Gavi. Now we don't want to waste 10 minutes warming or 13 to 15 minutes in vitrification, depending on the media you use. Now we have moved on to ultra rapid warming. Ultra rapid warming has been used. Vitrification is still under process, but warming has been validated now, and Lieberman did a good number of studies on ultra rapid warming. It's now just a one-step warming procedure. You don't have to go through your thawing solution, warming solution, dilution solutions. It's just one step now, and it's only 1 minute. So it's a cut down the time. The clinical pregnancy rate, as observed by Lieberman in his multiple studies, were almost equal, comparable to the current warming protocol that we use. There was a significant increase observed in the ongoing pregnancy rate in one of the studies, which is mentioned above, Fast and Furious. Implantation rate has also increased, but in a lot of different studies, which included more number of sample size, the data was almost equal. The miscarriage rates reduced with the one-step rehydration. So now what has happened is the rates are equal. So people will be like, why should we use these? Because it's saving you time. It's more efficient. There is a debate on the long-term application of this, which I think we will find out as time goes. But so far, warming has been validated. Vitrification is still in process, the ultra rapid vitrification. So warming medias, if it's available, you can definitely give them a try. It's very difficult to get them in India right now, but there are sometimes you can get like a sample or something. But they are great. They are very efficient. They save you a lot of time. And when we discuss technology and innovation, it's not about reducing our workload. It's being more efficient so that we can use that time in various other things, be it patient counseling, be it academics. So that is the idea you should go when you talk about innovation. It's not always about reducing workload. Electronic witnessing, everyone knows, so I will not discuss too much about this, but these are some of the devices that exist. There's a Biomatch and RI Witness, one on work on RFID chips. IMT Matcher works on barcode scanning. They are all good in their own ways. IMT Matcher is not too expensive. Biomatch and RI Witnesses are definitely more expensive, but the workflow is much more easier. Plus, you can also track how much time your embryologist who's working at the desk or inseminating is taking to complete that particular step. So it also helps in standardizing your practice, and witnessing also helps to safeguard you. And I think it's a really big part. We have been using electronic witnessing systems for some time now, and we are very happy with it because of the ease that they give when it comes to having a huge workflow. It helps you distinguish if you by chance make a mistake, and if you add 2 samples on the same desk, it will instantly ring an alarm so that you remove 1 sample and you work only 1 sample. So it keeps you accountable, it keeps you from slacking, and it also shows how much time you're taking for every step. So electronic witnessing in general, I think, is a great addition. And if we look at the Nobel Prize now in 2024, I'm not discussing PGT and IPGT because I think they're discussed quite often and almost everybody has an idea of how they work. NIPGT is non-invasive. It's sort of the new innovation that's come, that using the spent media culture. And PGT-A has existed for a longer amount of time now, but still both of them are not validated. Both of them don't offer a complete, I mean, they have existed for, PGT has existed for decades, but you still have no validation of the technology. So you can use it for certain patients that you want to. It certainly does help, but we cannot use it across the board, which is something that people keep asking, that PGT should be done for all. We cannot do it for all because there's no validation. And how automation and AI softwares have affected other fields is also visible. In 2024, Nobel Prize in Physics and Chemistry were both won by AI softwares. And especially chemistry one was really important because it helped design a protein structure of all the protein structures, and it could rebuild the protein structure to form new structures. What it does, it helps for us to treat diseases, because now we can actually have try the protein structure on a computational model before trying it on any of the organisms or humans. So big steps taken in AI innovation, and it is there in IVF as well. You can choose to ignore it, you can choose to debate about it, but sooner or later you will be using it. Day-to-day application, I think all of us have been using these softwares in almost everything that we do. These have existed. Probably you don't even remember how long AI softwares or algorithms have existed. Every time you go on a website and they ask you to choose, mark the zebra crossings, mark the dogs, mark the bikes. These are algorithms learning from you. So what has changed now with AI automation is the skill set evolution. The technology will support IVF centers. The technology will support embryologists. The technology will also help choosing patients and setting protocols for them. That patient selection is a big part of the automation and the AI driven innovation. Embryologist role will be involved into auditing, and people worried, don't worry, human expertise will always be the mainstay. And when it comes to quality control in your labs, maintaining an optimal environment for your culture systems, it's very important that you start using automated softwares, because they will warn you, they will record every single change throughout the day. Coming in, an embryologist would come in the morning. First thing they'll do is check the vitals. Last thing they'll do is check the vitals. What happens throughout the day, you don't know. So these systems help you track your machines, your very expensive machines, your cultures which are inside them throughout the day, from your VOCs, your temperature variations, your pH changes. Everything can be done with the help of AI and automation. And this will make life much more simpler for you. And all the alarms that ring sometimes when you are outside the lab and you have to run to check what's happened can also be avoided if you're aware of the trend of changes in the lab with the help of these algorithms. This is a video that I want to show you of how the conceivable life sciences or automated lab works. So I will just play this video, and I think it's a 4-minute video. We can just take a look on how it goes. Sorry, saying, yeah. Completely automated lab.
Hello.
The best part is that this lab is already
भैया
in
सर हैं क्या सर
existence
को दे
now.
देना निकाला क्या नहीं निकाला छोड़ नहीं मैं खाली उसी के लिए तेरे को बुलाई थी इसी करेंगे मुझे तो तू वेबिनार का तू बना के देता था
मैडम
यार
मैडम अनुराधा आपका
Anuradha,
माइक ऑन
please
है
mute.
So the dish is already now ready. No human involvement at all. Pick the sperm for you. And you don't even have to transfer the dishes from one platform to another. We'll see how it happens towards the end of the video. robotic ICSI, we have now moved to completely automated ICSIs. This is how the dishes are transferred from one platform to another. You don't have to do it manually. The robot will do it, and they record all the activity of how the dishes has been transferred. So you don't even have to worry about this. So this is essentially how it works. And this used to be a concept, but now a lab has already installed the automated system and they have been using it. So maybe very soon we'll see what are the success rates and the improvements they have received by using this completely automated IVF lab. So we have to adapt, we have to learn, we have to incorporate innovations in our IVF units so that we can grow. But also, while a lot of people talk about innovation, they forget that the traditional methods where they are good, they are good. So stick to them as well. Make innovation, use innovation according to your patient setup, your patient load, your IVF setup, and how much ever you can do. Not all the technology is important. Some will offer ease of use. Some are still going through the process of validation. Thank you.
Thank you. Thank you. It was really very informative, very good session. I want to know what will be the cost. What is the cost of fully automated lab? Can we?
It's very expensive.
Can we do it in India?
I mean,
Because
I think the
nowadays.
basic idea is this lab was basically Jack Cohen's idea, and there are 5-6 people, companies involved. It is called a $1 billion lab. And for a kind information, 10th April 2025, first baby using this technology is already born.
Yeah, it's in Mexico. So
Nee, that is
this
true.
lab is
That
already
is
being
true.
used now.
But for us, it will be a dream, I feel.
I think by the time it reaches a point where the use of it is so widespread, there will be other companies also coming into
Will
it and
come out
making
and
their own
reduce.
solutions.
The
We
cost may
don't know
reduce.
how big their labs or how automated their labs would be, but we certainly will have options available.
Yeah, yeah.
Dr. Anuradha, I think we can slightly compare with robotic surgery.
Surgery, laparoscopic surgery, ma'am.
10 years back, robotic surgery was considered only like few places could do it and
Yeah,
few
yeah.
doing. But now it is so common that everyone is planning. At least in corporates, you can plan. Maybe not in standalone.
Ma'am, it is very easy to do. Learning time is very less in robotic surgeries. What we learned by learning from others, like our teachers and all, it took at least 50-60 surgeries, then we are little bit confident. But now, after 10-20 surgeries, robotic laparoscopy is become so easy, everybody is starting doing.
So as I think Dr. Pratik has beautifully illustrated
Explained, yeah, ma'am.
videos and explained, it will probably require very good collaborative efforts, high-end units, and large volume of work in order to get this in, in practice. And probably India will be well poised to do it. Maybe in the coming decade, we do have automated labs all over the country, especially starting from metros. So thank you so much.
Thank you so much.
It
Yeah.
was a pleasure having you in Synergy. Thank you so much.
Thank you so much for having me.
Here,
Thank you.
Dr. Sanjay would like to say something.
So all in all, very good presentation, Prateek, but I think one aspect probably you forget to comment on is the microfluidics. It's not just about the microfluidic sperm separation, but the introduction of microfluidics in embryo culture, which in my opinion is going to be a big boon in coming years. So if time permits, can you comment on that?
Yes, absolutely. So while we have discussed a completely automated lab of such huge footprint, there's also a concept of IVF lab on a chip, where everything works through the principle of microfluidics. Now, in our body, microfluidics works in 3 different ways. There's thermal separation, there's gradient, and there's, of course, the changes in the pH from the fallopian tube to the uterus. So what we are doing with microfluidics, not just the sperm sorting, but for IVF as well, is trying to mimic these 3 gradients so that the flow mimics the flow from uterus, from the fallopian tube to the uterus. That is essentially the principle microfluidics is now based on. And the gradient separation has been already applied in separating sperms. It's so widely available. In fact, we have been using microfluidic sperm sorters for a couple of years now. And you can see the difference in picking up sperms. So it will naturally come into the whole, more than the sperm, the whole cycle to every step from denudation to ICSI, microfluidic. Once it comes, I think it becomes usable. It will be the first thing that will probably be adaptable by every center rather than an automated lab. So you're muted. You'll have to unmute yourself.
So this is it. I mean, microfluidics is again going to be in practice soon. There are few researchers who are working day and night out on this. Gary Smith is one of them. And another very important and very fascinating thing is about the usage of high frequency ultrasound to initiate motility even in testicular tissue, testicular sperms. So I do see that might also be incorporated in microfluidic separations and then induction of motility in those cells. So these are 2 cents from me. Once again, congratulations, wonderful presentation, and you rock as you always do.
Thank you, sir. Also, I think there's one other point that I would like to include because Manisha is here. Manisha is a great fan of omics, and I think omics will definitely take over PGT because transcriptomics and metabolomics have shown better, good result and actually giving us a better idea of the implantation potential compared to what PGTA does at this point.
That's why I brought about this microfluidics thing in the context, because these people, like I mentioned about Gary Smith, so they are working not just on the microfluidics to help the embryos to grow, but they are mimicking the entire fallopian tube. And at the same time, it offers the metabolomic, transcriptomic, and other omics studies from different areas of the microfluidic devices. So that will give you not just the good embryos, but also they can predict the ploidy status and they can also predict the competence of the embryo. So it's a wonderful project, similar to Jacques Cohen's conceivable science. I'm very optimistic about this.
Absolutely, sir. Absolutely.
We are very fortunate to also have Dr. Sanjay Makwana sir with us. So Sanjay sir, would you like to comment after your son's brilliant talk? Would you like to comment and be a part of our program? Please unmute, sir.
Sir, we can't hear you.
Sir, you have to unmute.
I was just going through the presentation, and of course, it is quite amazing to see how our labs are going to change. But it's still too early to say. But the surprising is, embryologists are talking about the automation and the newer aspect in the embryology lab. So, Dr. Sanjay Shukla is here. He can really highlight where the man behind the machine or machine behind the man will work in the embryology.
So it's very obvious. I mean, whether you accept it or not, it is going to come.
Yes.
Now it is up to us how, as this last slide of Pratik's tell us, that you will have to learn, you will have to adopt, and you will have to live with it. So, since the time immortal, there has been a lot of change in human life, but we have always triumphed over the machine. So I'm very optimistic. Let them come. We'll always be there.
And stay tuned with us. In our next session, we are going to discuss how we can introduce and how we can work hand in hand with these machines. Brilliant talk, Pratik. Thank you so much. Thank you so much for being here, Dr. Pratik and Dr. Rajmi ma'am. Over to you, Monica ma'am.
Yes, I think my role is very less, Manisha. I'm watching and listening to you brilliant personalities and gaining a lot of gray matter. So now we move on. Priya has joined and all the wonderful panelists have joined. So hi Priya and hi Nishad, hi Nancy, Vanshika, Preeti. And of course we have Kanav, we have Animesh, Sarguna Devi madam. So welcome all, and we can start our panel. Your panel is going to be started by Nandini Singh. Go ahead, Nandini.
Yes, ma'am. Thank you, ma'am. Good evening to one and all. Now we'll move forward to our much awaited panel discussion on the topic of decoding the IVF lab from foundation excellence to add-on innovation. To moderate the panel, I would like to invite our esteemed panel moderators, Dr. Priya Kannan madam and Dr. Manisha Vajpayee ma'am. Dr. Priya Kannan ma'am, madam is presently the director and embryologist at Garbha Rakshambigai Fertility Center in Chennai and Trichy. She is presently the secretary of Tamil Nadu chapter of IFS. She is also the secretary of IMA Chennai Kodambakam, and at the Chennai district she is one of the Chennai district coordinator at IMA NHP. Madam has also held the various past positions, and the most esteemed one is the past president of ACE. She has authorized various chapters in various textbooks, and she is a co-investigator in various esteemed research projects. We welcome you, ma'am. Our next moderator is Dr. Manisha Vajpayee madam. Madam is currently the head at the Department of Embryology and Research at Pacific Medical College, Udaipur. She is managing committee member of ISAR. She is executive committee member of ACE, and she is executive committee member of ISAR, Rajasthan. She is a peer reviewer of various international publications. She has been awarded various esteemed awards such as ISAR Shining Star in Embryology, ISAR Embryology Excellence Award, IFS Achievers Award, DSC Young Women Scientific Award, and ISAR Appreciation Award. It's an honor to have you, ma'am. We welcome you. Now moving to our galaxy of panelists. Our first panelist is Dr. Animesh Agarwal, sir. Sir is currently the director and chief embryologist at Ashoka IVF Care and Multi-Specialty Hospital. He is the chief embryologist there. Moving to our next panelist. Our next panelist is Ms. Doel Bose Pani, madam. Madam is ESHRE certified senior clinical embryologist, and she is currently working as the lab director at Indore Infertility Clinic. Our next panelist is Dr. Kanav Jain, sir. Sir is the scientific director at Jain Fertility and Mother Care Hospital, Jaipur. He is working as an embryologist. Our next panelist is Nancy Sharma, madam. Madam is the senior clinical embryologist, and she is working in in the Department of Reproductive Medicine at General IVF and Sons Memorial Nursing Home. Our next panelist is Mr. Nishad Kimote. Nishad Kimote, sir, has the fellowship of Indian College of Reproductive Medicine. He's working as an embryologist. Our next panelist is Dr. Preeti Bitta, madam. Madam is a senior clinical embryologist at Angel Fertility Clinic. She's also the founder director at Angel Fertility Clinic Private Limited. Our next panelist is Dr. Rahul Sen, sir. Sir is the executive, sir is the chief consultant embryologist at Neelkanth IVF Center in Rajasthan. He's the executive member of Academy of Clinical Embryologists, ACE India. Our next panelist is Dr. Sanket Dhumal Satya, sir. Sir is the ASHA certified clinical embryologist working at Apollo Fertility Center, Hyderabad. Our next panelist is Dr. Sarguna Devi Shivanantham. Madam is senior clinical embryologist working as the director of embryology at Dr. Arvind IVF Chain of Fertility Clinic. We welcome you, ma'am. Our next panelist is Dr. Shilpa Marwa, madam. Madam is PhD in clinical embryology from University. We welcome you, ma'am. Our next panelist is Dr. Vanshika Jain, madam. Madam is clinical embryologist at lab director and lab auditor, practicing embryology since 2016. And she is the first in Bhopal to give a healthy IVF pregnancy to a elderly female after 22 years of marriage. We congratulate you, ma'am, for this. Our next panelist is Dr. Varsha Jain, madam. Madam is the director of Pushpanjali Super Specialty Hospital in Bhopal. We welcome you, ma'am. Now, I request our moderators to kindly begin with the panel discussion.
So after such a brainstorming session by Raju ma'am and our own Dr. Pratik Makwana, let's begin the next episode. Get up with your mug of coffee and I hope my slides are visible.
Yes, Manisha, your slides are visible. If you can just do it. Yeah, that's perfect.
Thank you so much, Dr. Priya. So very good evening, everyone, and a warm welcome to you all to Coffee with Priya and Manisha. This isn't just another webinar. It's a relaxed, meaningful conversation over coffee about something we all live and breathe, our IVF labs. Before we start the discussion, I would really like to take a moment and thank Dr. Monica Singh ma'am for bringing me into this space and for choosing such a thoughtful topic. It is not often that we pause to reflect on the core of our daily practice, the IVF lab itself, which truly is the heart and soul of any ART unit. Touching upon this aspect, how we design, maintain, and continuously evolve our labs isn't just timely, it's necessary. So thank you, ma'am, for giving us a chance to re-examine, reconnect, and share what really goes into making our labs not just functional, but exceptional. We all are discussing since the beginning that labs are the heart and soul of beating heart of any ART clinic. But what makes them truly high performance beyond take-home baby rates? What defines its strength, its soul? Is it in the structure, the air, the equipment, or the people? So this evening, we are not just ticking boxes. We are decoding the blueprint of an IVF lab from foundational design and validated system to quality assurance and innovation. We were hearing about all these that are quietly changing the outcomes. So join in with your coffee mugs in hands, and let's begin this journey from essentials to excellence, from structure to strategy, and who knows, maybe we all will come away with something that help all of us build not just a better lab, but a stronger confidence in what we do every day. So to kick off our discussion today, I would love to hear from you all, from my exceptionally bright panelists, experienced panelists. In your view, what truly defines a high-performing IVF lab? Beyond just high take-home baby rates, what else is there, according to you? So, may I request Dr. Animesh, would you like to start?
Yeah. Good evening, everyone. Am I audible to everyone?
Yeah, absolutely.
Yeah. So yes, as you said that it is just not just about the take-home baby rate, but a high-performing IVF lab must have different qualities. Like when a junior and a senior embryologist is working in the lab, so their combination is something which creates the good environment. So the good environment in the lab is the first thing. Another thing, your lab. Sorry, your lab temperature and the pressure, the maintenance, if the
Dr. Nimesh, you are muted.
Coming to before that, when see, those are all the patterns that we would like to have to create a high performing lab. But what would you call, like, my lab is a good performing lab. It's more than good. It's a better performing lab. I mean, which lab would you call? On what basis would you call that? I think that's what Dr. Manisha is trying to say. I mean, we would have to look at all the things that we want to make the lab better, and not just good, not just better, but the high performing. But when do you reach the pinnacle of being a high performing lab? And what are the criteria you would take to say that?
Can I?
Hello.
Anybody, any of the panelists, please feel free to just.
I think the established
let's
KPIs
just
should be
put
met.
like 1, 2, 3, 4, 5 points instead of having a paragraph. Like, I think if you have this, that's a high performing lab. Let's just go like a rapid fire.
So we do the audits on the regular basis, on quarterly basis, right? So we do that. We send the lab cultures and everything.
No,
so
no,
if
no.
your lab
One
culture
point.
comes
One
in-
point. One criteria which you must be there to call itself a high
less
performing lab.
VOCs, less. So let's say the very less number of the VOCs.
Very less number of VOCs. Each one of our panelists can probably say one factor, please.
Sarguna, yeah, go ahead.
Consistently best performing result. Always consistency in good results. We all know what the benchmarks are and all that. So if you're consistently giving that with no matter what patient base, then I would say you are at a pinnacle of wherever you want to be.
So it's a low VOCs, a consistently performing laboratory.
It could be also meeting
Devi,
all the
yes,
KPIs.
go ahead.
Yeah, it is like the important laboratory KPIs. When they are on to the benchmarking, you are having a high performing laboratory that has to be maintained.
Yes. Also, it's to have those consistent results. Now we are starting to break down well, in the sense your KPIs always have to be on the notch. Is it like the acceptance level or the high better
Benchmarking,
level?
yeah, not the competence, but the benchmarking. Yes,
not the
international
nice to
standard.
know level, but the benchmarking level.
Yeah,
Yes,
because it's high
anybody,
performance.
Nisha?
Yeah, so what I feel to sum it up in as less words as possible is, for me, a high performing lab is, if we consider the new Istanbul consensus, we got all the KPIs, benchmarks, we got gold standards. For me, a lab.
Oh, that's already done. We want another point.
So the gold standard has to be your bottom line. It should be above that. So if you consider your KPIs, I have got solution. So if my lab is performing, it is having a blastocyst formation rate of 50 or 55. That is a quite high performing. That is my bottom. That is a high performance lab. So whatever.
Okay. So you're
KPIs are
calling
there,
the really good usable blastocyst would be your one of the criteria to call it a high performance lab.
Blastocyst utilization rate should be more than 50-60%. That is the benchmark. That is
Okay, great. That's a great criteria. So anybody wants to look at the lab and call it that how do I rank my lab? Means you have to look at the KPIs. You have to perform well, which means you have to have a consistently good level of usable or good quality blastocyst. Rahul, you want to say anything?
Yeah. Yes, I just want to say, like it's basically with the high performance, and I think the first point with the performance comes with the communication. So how's the communication between the embryologist, clinicians, and all the other team members? That communication is basically the first step for getting a good performance in an IVF lab. So if it's a good communication
Great,
between
great.
consultant and
So
embryologist,
what Rahul is saying is yes, you have to have results, but that results come only when there is good communication between the junior embryologist to the senior embryologist and between the embryology team and the clinical team. And that is when the patient actually benefits.
Yeah. So Kana
Perfect.
and Preeti, they are the youngest, and Nancy. So would you like?
Yes.
Yeah.
So, adding on to Dr. Rahul's take, there is one more thing which is important: transparency with the patient. So, it is also
Super.
important when we consider talking to our doctors and embryologists. There should also be transparency between the patient, doctor, and embryologist too. So that will also add to a good quality of lab. And talking about the benchmarks and the KPIs, it should be closer to the benchmark, as Dr. Nishad said. Crossing the benchmark could be your expectations, but it should always be closer to the benchmark whenever you talk about KPIs.
Perfect. Superb. Bringing in the transparency is it's a consistently, it's a good one. It's really good. Yes. Any other point?
I think at the same time, you also have to take into account the kind of patients you are getting, because when you are talking of large numbers, yes, you can talk of KPIs. But if you are, let us say, if it is a smaller lab, if it is a newer lab, and you are consistently getting patients who are with advanced age or really low AMH or other problems which are compounding your results, then you may not be able to match the KPIs. But that does not mean your lab is not a high performing lab.
Great. That's a great point to bring around. And that's when you have the embryology clinical correlation of each, so that we know where we stand. We're not going to expect a 60% blastulation rate in a 42-year-old. So that's exactly what your point is. Amazing. That's right. Anything else?
I think the pre-treatment communication between the embryologist and the clinician is a must.
Okay.
Usually what happens is the embryologists are only consulted after the egg retrieval and maybe during the semen analysis or something, but we forget to sit down with the clinician and even the nursing team per se, and then decide on the kind of protocol that you want to carry on for the clinical part and also for the embryology part. I think that's a must. And once, I think that's going to help with hitting the benchmark or the KPI sets as well. That's a personal opinion, and that's something I practice in my lab as well. So that might be helpful too.
That's great. So I think here, Manisha, I think we've got almost all points, isn't it?
Beautifully.
That's great. So we start with the communication. The ideal thing is we want consistent results. And for that, we would need benchmarking of, we need to hit the benchmark levels and not just the nice to know have levels, which means what would be best would be a cumulative effect of all the KPIs would be to have good quality usable blastocysts. That is probably the end point of our culture, and the best of blastocysts we have, we know that our culture system is working well. And for that, we'll be maintaining everything. And more importantly, we need to have that communication and with the clinical team, and the clinical team always has to keep the embryology team and into confidence to say, day one, this patient, the file goes to the lab to say this patient is coming for stimulation. So we know what we are looking at. And of course, transparency is the key to any lab, which means we are confident of what we are doing. And hence, if there is any slight change in the protocol inadvertently, or we had to do that, or there's been any mistakes, we should be open about it to, like, I always like my junior embryologist to be free to tell me I made this mistake. So we know what to do. I don't want to find out anything after some time written in that small notes in the bottom of the notebook that this has happened. So that way, and if there's been anything, go to the clinician, and how they have to convey to the patient, let them do it. So great. I think we have set the benchmark of what should be the high performing lab. Over to you, Manisha.
Oh, amazingly sum up, Dr. Priya. It's such a pleasure and it's such a blessing to have you with us. Beautifully summed up. Why don't you the next question? Okay, I'm taking it. We have discussed about the high performance expectations and ideal setup. So let's start with the basics. The physical space we work day in, day out, and it makes a huge impact. Why? So I would like to know what kind of architectural and environmental feature do you feel really make a difference in creating optimal embryo culture conditions in meeting out your desired gold standard KPIs. So who is going to take it up? Sharguna? Yeah, we would love to hear you.
Yes. When it comes to architectural features, first of all, you may have to decide. In India, it may not be possible, but you have to be away from the traffic and the construction sites, but it's going to be in the middle of the city, so we have no clue. So obviously we have to think about the materials, what we use for the construction, to use the space efficiently and to have less VOC emission from the materials, as well as less embryotoxic materials used. This is the first thing when it comes to architecture, because obviously that is going to, you have the modular OT and laboratory now available. So you can just design your lab accordingly. And then when it comes to the environmental features, I would just think like it's the temperature control, the humidity control, as well as the air quality control within the laboratory using the desired measures. Yeah.
Anybody wants to add, please?
Sure. It's,
I
it's
would
a very
just
big
like to
subject,
add
I
on
will say.
that.
Yeah.
Yeah, go on. Yes, yes, sure.
So it's a very big subject when it comes to lab designing. I'm very passionate about it. And if I just may say that in today's time, most important thing is we need to make sure that it is a sustainable lab for the next 20, 30 years. You need to have basic things like the materials that you are using has to be eco-friendly. You might have a solar panel, you might have something else that will save your electricity and the power consumption, because at the end of the day, you can construct a lab in 50 lakhs to 1 crore. Problem is it sustainable? Are you able to maintain the lab? So if you can use products that will lessen the amount of things that are used for maintenance, for example, using the silver nanoparticulates modules like there are available in the market. Those panels are used, you just use distilled water to clean it. So these are the small things that can make a lot of difference. The flooring has to be a different kind. Today we are using epoxy, but now new materials are there in the market. You can use them. So you need not use products like Safe and all, which are very expensive. This reduces the cost. So second is automation in the lab. By controlling the humidity, the temperature, if people are more, then the AC will work more. These are the small things that will make a lot of difference.
We'll be covering automation in next few questions. Nishad, we are certainly going to talk about it. So we are actually anything about the construction or architectural or environmental part, if remaining, if anybody has.
So basic
Yeah, I would like to add on.
The basic thing that is there, the Cairo consensus also mentions is no use of wood, no use of MDF. These are the small things you cannot use that exude VOC. The most important thing is when you're using fixing your UPVC doors or aluminium doors or even the windows, simple and the smallest thing is not to use the silicone material that is used for adhesive. There are two types. One is a non-VOC, which is expensive, which you have to import. So when you're doing this, get that, because generally the labs which are prepared by the companies or the people who make lab for you, they forget to use it, and the next 6 to 8 months, the VOC levels are very high. It does not go away. So that is a small tip I would like to give. Use non-VOC silicone gels for adhesives.
Great. Anybody else wants to add anything else?
I think
yeah, ma'am, I would
noise
just like to tell
So
that,
I guess I think one of the key things with Nishad said was
in our country, I think it's not only about how much you put inside the lab, but we have to look what is adjacent to the lab also. So I have seen labs, they have made it very beautifully from inside, but adjacent to the lab, there is a water tank, or there is another building in where the construction is continuously going on. So we don't want that unnecessary vibrations and unnecessary seepage or any leakage, right? So we have to see what is above the lab. If you are making the lab on the ground floor or a first floor where there is above there is another floor. We have to also see what is adjacent to the wall lab, so that if there is any water tank or any washroom, so we don't want that leakage or any seepage in our lab.
So just to ask, in which floor would you like your IVF lab to be?
Not
Basement,
preferably not on
ground
the
floor, first floor, second floor,
preferably
or
not at
even
the
above
ground floor.
that, anything is fine.
Ma'am, preferably not at the ground floor, because if we talk about the air quality index of our country, so it is better not to put it on the ground floor. There are a lot of chances of the outer environmental and inner environmental in the lab to breach. People can come easily, because there will be a lot of disturbance in the ground floor always than the first floor or the second floor.
So it's not in the basement, it's not in the ground floor. Any floor
Basement
else
definitely
is
no.
fine.
Yes.
I would disagree.
Or
It
even in the
shouldn't-
top floor.
It shouldn't be above second or third floor. Simple
Yes.
logic. If there is a fire hazard, we should be able to shift the liquid nitrogen canisters.
True.
So it is easier to shift, because that is the only thing that
So
you want to
it's either
save
in the
in
first or
lab,
second
every
floor.
embryo. Second, third floor max. That is the convenience of shifting
First
the
or
big
second floor. That's
unit.
what you would prefer, Nishad?
Absolutely, yeah.
Yeah,
Yes,
perfect.
Are we talking,
Anything,
are we
anybody
talking
else?
about standalone IVF labs, or these IVF labs are part of a larger hospital? Because I think that would change a lot of your fire hazards and how you can transport stuff around.
That's a good point.
But I think
That's a
nowadays,
good point.
nowadays, as per the law, even if you are having an isolated IVF lab or you are having it in a multi-speciality hospital, you have to follow all the fire norms, the fire exit plan, the fire fitting. It's must.
True, that is there. To get your CEA, you need to have this fire safety in place.
So I think
Yeah,
purely
before-
on the question of liquid nitrogen, if it is part of a larger hospital with very extensive fire safety norms, I think those should be in place, and liquid nitrogen to transport the embryos, I think those should still it should be okay.
able to be transported.
Just
That's a
from
very
that-
good
that
point. That's a
one
very
point.
good point. Yes.
I think
So in that case, just to talk about this, so we have set our IVF lab, and one of the key things I've seen when they set IVF labs and have the AHU is from where the AHU is taking the air from. If it is the next one is a restaurant, and this thing, the input is from near the exhaust of the restaurant, and the whole thing is gone. So I guess that's what everybody has been saying, that the details, the devil is in the details. So when we put the AHU in, it is not just putting the AHU in, but to know from where the air is coming, and from there we are getting it, and where, even if you have a generator, where the exhaust of the generator is, so is it anywhere near the AHU input air intake? So those things need to be taken care of at all points of time. So I think, can we move to the next question?
Ma'am, why don't you take it, please?
Okay. So, okay, now that we all have decided what is going to be our benchmark, and then we have constructed our lab. So now we are going to set up a lab, and we need to order the equipment. So what equipments would you make it as a mandatory for any lab to have, and some good to have equipments which might differentiate our lab from another lab in terms of, let's say, to have not the luxury ones, but the ones which can actually lead to our high performance lab?
I think everybody should have or own at least one gas analyzer or a pH meter or something, because that's very important. You cannot always ask the EME team to come in if something goes wrong. And if you have embryos in culture, you should be at least be able, or your junior should be able to do the gas analysis. Like we do it every morning, in the morning and the evening, and especially in places like mine, where we have 6 time season changes in a year, and the humidity keeps on fluctuating, and we have to make sure that the pH is right. We have to make sure the temperature is right. So I think a gas analyzer and the pH analyzer would be perfect. Can't see it, Nishad.
That's beautiful. That's exactly which I really like. Whenever I set a lab, I insist that you should have a gas analyzer. A CMO analyzer, if you don't have, then I always say you must invest in it. That's something I really insist on any lab investing in. Any other things? Do we
It's
all
like
have
other
a
QC
VOC
machines we
meter
need to
running?
really think of. Other QC machines, because just not the CO2 analyzer. I'm adding up that point.
Yes,
You need
please.
to have a
What other
temperature.
QC machines you would want?
Yeah, I definitely want to read the temperature. So there is a temperature reading machine. I have a thermocouple kind of, and pH meter, because not all the incubators we can just do a CO2 analysis. So rather some benchtops you may not be having provision for that. So you may have to have a pH meter so that you are going into the exact pH of the culture media where we are culturing the embryos. Otherwise, when it comes to equipment, it is going to be the budget and the space. This is what and the workload. These
And
3
how
points
many
are
of
more
you have a
important.
24-hour VOC meter running? Oh,
yeah.
Yes,
That's
we do.
most of us. I think that's great. So I think we have criteria fixing, it's easy to have high performance lab with such things, because I think it's in the details, and this is what is important. I also wanted to know, see, our law dictates that we need to have certain set of equipments with us, right?
Yeah.
So above and over it, is that enough to have run a IVF lab, or is it inadequate in any part of lab, or is it good? You can run a lab with that.
The law doesn't mention that you need a benchtop incubator, if I'm not wrong. It mentions you just need an incubator. So I think a benchtop incubator is a must-have. At least one, at least. I mean, 2, I think ideal, but at least one benchtop. You should not be culturing embryos in ambient atmospheric, oxygen level.
See, actually,
I
the
think
law is not mentioned about the technology, the evolving technology. The law is mentioned only about the minimum number of equipments that can justify a proper working in an IVF lab.
But
There is nothing related to technology or what is going to be there.
benchtop, Rahul. The minimum equipment list, I'm sorry to say, I will 20,000 times shout if I have to, because people don't culture in benchtop incubators, which you should read the latest version of David Gardner's. You would see what he mentions. I'll send a screenshot across. It is kind of ethically wrong to not culture in a benchtop. So this is what he mentions. You should check the
No,
chapter.
but see, I differ here, because if you are getting good result from the conventional, the box type incubator, it doesn't matter. But yes, for our safety purpose, one should have a benchtop
The
incubator.
result is not just the
benchtop.
live birth. The
So,
result is long-term, which we.
I want to add on one point
Yeah,
that
please.
even a box incubator can have a trigas.
Exactly.
So, for example,
Yes,
Binder incubator. So it's
yes,
not the
yes,
benchtop or the box incubator.
Do you know
But
how much
obviously,
Recovery rates will be different.
that is also going to have low
I
CO2.
think-
So it's
I
just
think
a matter of the workload.
It's
if we have a poll here,
trigas. Do you know what the operational cost of a trigas? Did you do the calculation to see if you open it 3 times and you have a 15-liter of box, right? So how much trigas are you is expulsing out? So it is operation cost-wise, it becomes very heavy.
Also, the
I
time it
have a
takes
benchtop
to recalibrate
incubator
it
in
is
all the
17
senses.
to 18 minutes if you open the door. Here it happens in 4 minutes. So the exposure time, the change of pH osmolarity will happen more. Also, you have to understand that in a smaller capacity, the surface area to volume ratio is more. So the heating will happen quickly. The gas will come back quickly. That is why benchtop is better. Also, that is why in the law it is mentioned 2 incubators. They have not mentioned which one. So it is basically the job of the embryologist when you are putting a new lab, mention that go for 1 benchtop, 1 go for a box incubator.
Exactly.
That's great.
So,
I think myself and Manisha, we love that
Seriously.
little thing on the sofa when we were enjoying our coffee. So I think it's great. Culture of embryos and the conditions has been evolving. Yes, what we have in the law is the basic thing that we need to do. You can run a lab with it. It's not that you cannot. But to have a high performance laboratory, I think to have a benchtop is good to have if you want to have a high performance laboratory, so that it is also good for the embryos according to the present principle of culture. everything science is evolving, it's evidence-based. There was a time we used to use only sequential, but now we are using only single step. Before that, we were using only single step. So it was single step to sequential to now single step again. So that way we keep evolving. So now it is 5%. So before it was 20%. We may not know what happens in 5 years later, but according to the culture conditions of present times, it is good to have a benchtop so that our blastulation rate is high, and we do have a high performance laboratory. And what Nishad said is also valid, that yes, you can have a box type trigas incubator, but the maintenance of it could be quite not very cost effective because of opening and closing. The volume loss and the volume relocation is quite high. The next question, please.
Can I add one more point? It's a very small point, but this is what I wanted to show. This is a 1,500 rupees.
We can't
Okay.
see. You need to share your screen. Share your
Yeah,
screen.
okay.
What is that?
This is a 1,500 rupees temperature and humidifier sensor, which you can automate with your phone. You can keep it in your fridge so you can monitor if the cold chain is maintained or not. Because everything you have to blame the media if the fridge is not working. Plus you can monitor it 24/7. So even if you keep it in your lab, you can keep it near the incubator. You can keep 4 or 5 of these and just monitor. It does the job for you in 1,500 rupees. That's it. You don't need a very expensive setup.
Wonderful, wonderful, Nishad. Your
Nice,
input.
Nishad. Thank you. Share it on the WhatsApp to all of us.
Yeah.
It's Taco.
Okay. Okay. And and along with all these pointers, I would like to add just one more point. Calibration of your calibrating QC equipment. That is something, again, very, very necessary. So please keep that in mind along with this. So we are lab people. We are very, very fascinated with the numbers, data, which is being generated in our lab. So we are definitely very fascinated. We are talking about KPIs. So let's talk numbers, because some metrics really tell us how we are doing on the grounds. Which performance indicator do you think are the must? Which one do you do personally track regularly? My panelist, which KPI you really believe in, you are doing regularly? Be honest and share with us.
From my side,
So when it comes
I
to
think there are the two
laboratory
KPIs.
performance,
From my
Someone
side,
talking?
from my side, I think there are the two KPIs which I basically regularly monitor. One is the fertilization rate, that not only signifies how the formation of embryo has begun. This will also signifies how an embryologist is working in the lab. Efficiency of an embryologist is also can be correlated with the rate of fertilization and the usable number of blastocysts. So these two parameters, I think they should be non-negotiable in a top performing lab.
Rahul, can I just slightly not go with your slightly disagree, slightly? Because now there are papers, there are so many papers, even the ASRM consensus is there. Then there is one VIXI one, the Danish publication recently that happened, like just in April 2025. So they say that fertilization rate is not that good a marker, because with IVF, you get results where fertilization is less, ICSI, it is better. But your blastocyst formation rate and your end result, even pregnancy, is better with IVF. So somewhere fertilization rate, I would not consider as a top one. I agree with you on the blastocyst utilization rate and the blastocyst formation rate.
That's why I have rolled this my answer, that I am checking the efficiency of an embryologist as a fertilization rate marker. So I am checking
then rather than fertilization, I would not say. Then it is the ICSI regeneration rate, not the fertilization rate.
Okay, so I would just like to add on one point, because it's a top performing IVF lab. That's what we need to underline. Each KPI is going to be important, starting from the maturity rate, because that's where we are getting our raw material. It has to be the maturity rate, fertilization, cleavage, as well as the blastocyst. freezable blastocyst rate, and earth or survival rate. So everything matters for a top performing laboratory.
Exactly. All the KPIs are very important, and they can use to predict the shift in the clinical outcomes also. So it is unfair to take only one KPI. We can take only taking the single matrix. It's very unfair. We can use combination of KPIs to
So
take.
what combination you are using and how often? This is my question actually.
We can use as Nishad said, blastocyst rate is very important. We can also use implantation rate. See, these are the combination you can use. Fertilization rate is always overlooked, but it is also very important to see if the fertilization is proper or not. It should be closer to the benchmark.
Yeah. We study the KPIs every month. It's a monthly KPI check.
Combinations are important. We cannot talk on the single KPI. All the things are important. Everything inside the lab is important, and every KPI is also important. They take their own role and they have their own importance. So when we talk about the clinical shifts, it is important. You have to take care of everything.
I think I'll add to what Nancy said. Sorry, ma'am.
It's okay, Preeti.
I think the most important KPI not to miss is multifetal pregnancy rate and then missed abortions. I think these needed to be addressed as well, especially from the embryologist point as well. What I do is if the multifetal rate exceeds 10%, the clinician is going to yell at me. So I have to be very careful that, you know, the number of the embryo, the blastocyst or the cleavage embryos I'm transferring has to match the original goal. And at the same time, I think the missed abortion rate as well, because I think that kind of gives us insight into the quality of the blastocyst or the embryos we're transferring. So I think these two are also that I usually have been doing.
We do check the KPIs every month.
Yeah.
It's a monthly audit of the KPIs, unless there is some drop, and then you're just looking at it all of a sudden at a point. And we just see the process KPIs as well as outcome KPIs. There are two different ways we look at everything and then do the audit every month.
I look at the clinical KPI whenever something goes wrong first. See, if they don't give us enough M2 at exceed, I mean, that is the first KPI that we would go back.
So implantation rate is the one you look for.
No, M2 at exceed.
But I agree what Preeti said.
How
Miscarriage
many
is
of you
very
say,
important.
I think, yeah,
Because
it's a
that
great
determines
thing.
the quality. Obviously, the endometrium is also involved, but somewhere it also tells us whether the blastocyst quality is good or not. So utilizable rate of blastocyst is also another parameter that we should consider.
True.
I think everything culminates to the utilization. Blastocyst utilization rate. I think it culminates there. So
Right.
from the number of eggs to the maturity to fertilization rate to everything, if everything is well, only it can culminate in maximum utilizable blastocyst rate. So I think that's like sort of a culmination. But when we want to add to that, everything else has to be looked into so that we can land up there. So we can't just start running. We have to get up, walk, and then run. So I think every point is important. So we will have to go. But then what Manisha is trying to ask is every day.
Yeah, Dr. Priya.
Is there anything like that, or you do everything every day?
No. Sorry, it was breaking. So can you repeat the question?
The sense that is there any particular thing you would like to do on a daily basis? Your QCs?
QCs.
Yeah, definitely.
QCs tons.
It's daily, yeah.
So
Every day is just observation.
I think fertility is something we log in every day as soon as we see the embryos after the 2 p.m. and the cleavage. And I think for the QC and everything, the regular temperature, humidity checks, the VOC check, all the parameters, whatever we can see on daily basis and whatever the meter shows. And I think it is very important especially if you're culturing the embryos or trying to equilibrate the media, I think you have to do the gas analysis as well. And for the benchtop incubators, what I would like to do is once a week, do the temperature checks for all the chambers.
See, basically,
So
how busy the lab is basically. If you're doing a batch and you're having like 20, 30 cases in 1 week, for example. So at least 1 week before and 1 week after, you should continuously monitor. So that is what you should do.
Yeah.
So at least
Outside
get
the
time to prepare what is going on, and after that also it can be followed at till what time it was maintained.
outside the
That's
laboratory
the
checks,
benefit of having
routine
a
laboratory.
junior,
Sorry.
right? That you can do QCs regularly.
Just want to add one thing that we check the
regular cases, then yes, because I do regular cases, I do it every day. That's a different story. But there are people who do batches. So when the lab is not working for a week or so they can relax for that time being. Not CO2, you need not monitor every day.
Not every
in
day.
the lab, yes, but not in the incubator.
Right.
So outside the laboratory checks, I would
Yes.
like to check the tank levels, cryopreservation, the liquid addition tank levels every single day, because you need to really monitor they're working well. Yeah.
Right.
Unless you have a continuous monitoring system. So it's everyday check,
Yeah. So
preferably morning and evening. Yes.
for that purposes, as Dr. Nishad told, nowadays there are lots of gadgets which even we use in our lab, which can be connected to a mobile, and even if you are not in the lab, you can monitor them. You can monitor the temperature, pressure, and you can have the alarm system as well, so you can get the alarm if something goes wrong.
Here I
And then
I
you can
wanted to know the KPIs, the key performance indicator, not the
QC.
rescue system we
QC.
have in our
Because there
lab.
was a question about QC, right? Yeah.
Yeah.
Quality control for
Yeah,
that.
yeah. No, the Priya asked about QC.
See, there are few things which can be checked on daily basis.
Mhm.
These are that can include temperature, humidity inside the lab. See, and there are few things which can be checked on weekly basis and then monthly basis. So there is quality control and then quality assurance. And so total quality management system should be worked in an alliance. So,
Yeah.
We are
QC
still on the
parameter-
KPIs, right? Yeah.
That's
Are
what
we still on the KPIs?
parameter.
Dr. Priya.
One parameter I think which is not mentioned here is HCHO, formaldehyde. I think that is the most important one, because that is going to affect the embryo culture or the embryo growth. So that has to be 0.5 microgram per meter. That has to be, or every day that has to be checked if you're culturing the embryos.
Okay. Is it, are you?
See, there's one more, Manisha, I'll just make a point. There's one more point I always wonder, which is never talked about, is to check the osmolarity of the drops that have been made. Because if you're making it on a warm plate and it takes a longer time, if you have a junior embryologist, just takes slightly longer, then the evaporation can significantly change the kind of results you're going to get. So we talk about pH, we talk about temperature, but never you're talking about the osmolarity of the drop that you're making. So if you're doing it in a large volume, then it may not matter much, but in smaller volumes, it is very, very essential that the osmolarity is also checked, because that can also affect the outcomes very, very significantly.
Yeah, that would really relate to the training what we give to the juniors, and then check their competency and sign them off for a particular procedure. So well-written SOPs and a proper training and reviewing and signing off would help, because we can't be checking that every
Absolutely,
single day.
very true.
So obviously it has to go.
Very true.
And not making 5 dishes at a time. Just make 1 or 2, then shift. About meat,
Yeah, that is
smaller
true.
tubes. That's
There
how
are
you
not
maintain.
many
If you're
questions.
doing a batch, even then.
And
Simple logic.
just one more
You
point.
cannot goof up with osmolarity if you're using smaller quantity in smaller aliquots and making lesser amount of dishes.
There are many things we are going to discuss, and probably we are going to cover all these things in our upcoming questions. So we have just covered almost everything about the KPIs and QA/QC system. So when we know the numbers, it's all about keeping the system tight. So what quality control and assurance system do you rely on, and how often do you go through internal audits, checks, sometimes despite everything? So what is
So yeah, I have used continuous monitoring system in the past. So that was quite easy. Then it has a direct entry from itself, and we have connected to the alarms and we were attending. So it was quite easy. So again, then now it is just a manual check. So you have to prepare your daily QC, bi-weekly, weekly, fortnightly, monthly, quarterly, biannually, and annually. So you have to have a set of SOPs to do the checks, and almost every day you're checking into your daily QCs and the cryopreservation QCs as well. But at the same time, every week I go through everything, like not just me, like all the senior embryologists in the team, they have to look upon every center that their QCs were not varying anywhere, not deviating anywhere. So this is what we need to do. So it goes like around the clock, we are doing something throughout the year. This is how the QA/QC goes in there. And when it comes to some non-conformities and some incidents happening, immediately we're going to look upon what we are going to do. So do a root cause analysis, do a reactive as well as proactive management of it. So the thorough knowledge from the laboratory
We'll be
head is
coming
going
to
to
that
give all the information.
when things are not going right. So about QA/QC, anybody would like to add anything? What QC you are doing routinely and how often you are doing them? A message to our fellow junior embryologists or the clinicians if they want to know. Anybody?
See, if I have to compile that what QC is and how we do it, and it is like what we do, we see what is safer today. And when it comes to assurance, we make sure that what is safer for tomorrow.
Right.
And both come under total quality management, and everything has their own time period. There should be internal audits, there should be external audits. External audits, I mean third party audits.
Right.
And the things, the equipments, gadgets you are using for the internal audits, that they should be also externally audited.
Absolutely.
So something
That's
which
clear. I think that is almost summed up the topic on QA and QC. So, is there anything else we have to? I think
Yeah, I think
this is
one-
also something we have already discussed, isn't it?
Yeah.
Quite elaborately, we have talked about KPIs, QC, QA, the implementation of the same, and to look at what to do when. Some to be done daily, some quarterly, some monthly, some at the year end, and some externally as well. So
shall we skip this question?
yeah, I think we have discussed this a lot. Yeah.
So
and we'll just go straight to their add-ons. So I think those are very important
More
ones.
interesting, yeah.
Everybody likes add-ons. So, so as we know, there are important aspects in the lab, and there are some which are add-ons. Like we have the time lapse to AI, to NIPGT, to MATS, IMSI. Is there any add-on which is quite, let's say, which makes a difference in the lab?
Yeah,
I would try to say it's a big
One of you,
let's-
okay. This also, it'll be a rapid fire round. Each one of you will name one. If you have anything, if you don't have anything that doesn't add value than what we already have, you can say none. So all of you will say one. Yes, go ahead. Devi, you start, please.
Yeah. So I want to add two because
Just
this
one
is a
word from
personal,
each of you.
Personal,
One word.
personal experience. Yes. Okay. So artificial oocyte activation.
Okay. Next, Nishad, go
fertilization
ahead.
failure.
CASA, semen analysis. CASA.
Okay.
CASA.
Anybody? Everybody? Nancy?
Out of 17, mine is microfluidics. It is recommended.
Yes.
Okay.
If I have
then
the money, polarized microscope, polarized microscopy.
Polarized microscopy. Wow.
I want to see if I have the money, because we get a lot of patients these days with just.
Okay. No background. Just word. Just the answer. Yes, go ahead.
If I have the
Rahul?
money, then.
time lapse.
Oh,
Time lapse. He's got expensive
Add-ons.
add-ons.
Without
Yeah.
AI.
People once were
It's-
taking my
Without
others.
AI.
Are you, Rahul, are you getting any betterment in results because you are using time lapse from quite some time?
Yeah,
Just brief, yes or no? Any betterment?
Yes. It's not. It's basically not increasing the result, but yes, there are some parameters that can actually help.
Yeah,
you.
it's
Deselection. Yeah.
yeah, exactly. Yes, go ahead.
So, Preeti?
I think hyaluronan binding, sperm sorting, or microfluidics.
Oh,
Both.
wonderful. Animesh?
I think time lapse.
Okay, wonderful.
Wow, boys have like the expensive toys.
Another fancy toy in my lab.
Yeah.
So in my usage of time lapse, there was a difference about 10% higher clinical pregnancy rate. It's past. Currently, I'm not using it.
Kanav, Vanshika, I couldn't see you.
I think she
I think if I get a lot of money, I'm going to put that automatic lab that Pratik showed.
Love that.
Everybody would love to have it, I guess.
We'll be coming to that even. How you are going to implement that lab? I would like to discuss that point
later. But then I
Money
think have
first,
we all
money
finished?
first for that lab.
Manisha, do you have any add-ons that you would like?
Definitely time lapse. I
Oh,
want
time lapse. Okay.
consistent
My
balance.
favorite add-on for the moment is an embryo glue.
Oh, lovely.
Yes.
Oh, really?
There is a
Yes.
cushion. There is a cushion,
Yeah,
and
I
would like to know
you
why.
just had
How?
experiment.
Priya,
See,
I would
any
like
of
to
the
know how
add-ons
now.
what I have used, I have not seen a significant
Yeah.
improvement when I was doing the data, but this AOA, it was certainly improving the fertilization
Okay.
rate at least
Okay.
10 to 20. So it's from the personal experience. It's just not what I.
Right. Great. Next question now, Manisha.
So
We have
somebody
close
was
the time.
saying that they want to use automation, totally automated lab. So how do you maintain a balance between using a new tech tool and good old embryologist instincts? So how you are going to maintain
People
balance?
who don't adjust to technology become history.
Wow, lovely.
I think I'm
So
just
you
purchase a
have to be the master of the technology, not the victim, ma'am. So
Yeah, exactly.
definitely.
We
So
need
how?
to master it, otherwise we are
If
history.
we are given a choice of just purchasing one of the boxes, I'll do the equilibration box. The one which automatically makes dishes.
Yes.
Be
So I
part
guess
of the billion.
I think the bottom line is whenever there is an improvement in technology, we have to know the technology and be above it and not just scrub up to a technology or be in awe of it. We have learned so much technology. This is just another one. That's it.
I think
What I
validation
feel
is
is,
the
I would
major
like to
major
add,
aspect that to be
time,
covered.
Priya, may I?
I
Can I?
think validation should be the major aspect that should be looked upon for
Yeah,
any new
true. I mean,
technology.
validation is part and parcel of our thing.
Yes. So
Yeah.
quickly to
I
our
would-
next.
I would like to add artificial intelligence software for all the data analysis. That is the headache we have.
I know
Big
that's a
QC
headache
data,
we would
big
all like
results,
to,
patient
and
data.
for embryo selection as well. Like, if
Right,
there is some
right.
which is for embryo selection, I would love to use it.
Right. Actually, time lapse without AI is nothing. So
Yes.
definitely anything with AI is going to be future.
Yes.
So actually, there are some exciting technologies, some are under study. So when it comes to the lab add-ons, like spindle imaging, Doyle was saying, or microfluidics, or embryo glue, how do you decide what is worth exploring or offering?
Whatever is achievable monetarily is the first one that you tried.
But Doyle, we can't forget that we are using biological material of somebody's expectations, dreams, and somebody's money. So even if you can afford it, you
It
have
is
to be
your own
very
data. So
See,
how
I
you
think
optimize the-
we need to go with
it is evident.
both. You need to have both personal experience and also look at evidence because, for example, embryo glue some point of time before did not show any improvement. But now it is shown to have some improvement in your results. So it might be worthwhile using in people who have had recurrent pregnancy losses or who's got recurrent implantation failures, not for everyone. As I always say, you can give paracetamol, but it works only in people who have fever. You can't give paracetamol to the entire population. So it's just like that. You select your cases. For example, oocyte activation, when you know that the previous time there's been a problem, use oocyte activation. You can improve on the number of oocytes you actually you have on hand to use. You increase the number of raw material. Obviously, your results could be better than before. So every time, for example, in terms of hyaluron pixie, it has shown to decrease miscarriage rate. So we should be looking at the indication. I mean, what it is best used for, and then use it. It's there. Somebody has done the study. Let's just use it. We don't have to go ahead and do the studies.
Wonderful. But how much to rely on those studies? Because when you get a study in favor of a particular gizmo, you get a contradictory study as well very soon. So how to rely on the data?
Personally, you will have to get that confidence.
Yeah. So coming to the very apt next question, if patient asks you about the, finally, everything boils down to patient's perspective, because what all we all get to ask about add-ons during counseling. If a patient asks you about the lab-based add-on with a limited evidence, how do you approach those discussions?
I think you understand, if you're yourself sold on something, it is easy to convince or counsel somebody. If you're not sold on something, then it is kind of difficult to do it. So choose an add-on that you really think you understand, not just because you heard it somewhere and you didn't even read about it and you offer it. That's not right to do. If you understand it, if you are yourself convinced that it is easier to tell them, and then this is so and so, and go forward with whatever your suggestion is.
In my experience, yeah, in my
It's the
experience, it was
evidence-based
like,
medicine era. So nowadays patients are very well aware. And if you are charging them for any add-on, they definitely gonna ask you about the. They're definitely gonna read it about it from somewhere and come and question you. So you better be prepared for that. So if you are giving them any AI-based image, or if you are using any add-on, you should be well thorough about the topic, and then explain the patient that this is going to be like this. This is the probability from this add-on. If you use this add-on, this is going to be the probability, or the success rate. And if you're going for some other add-on, this is going to be the probability. And let the patient choose. So if something goes wrong also, the patient does not blame you. Ultimately, it will be the choice of the patient to choose the add-on.
It is all about your counseling, because the patient will understand
Yeah.
what you are counseling them, and you will be counseling what you feel right.
Hey, but the choice should be of the
can't be
patient.
that correct all the time. So because the theoretical data, we always see a contradictory reports, contradictory evidences. So how to make up your mind to implement that newer technology in our lab with the confidence?
Then again, about that, for that you have to choose the patient. For then the patient case selection.
We
Case
just have
selection
to
should be there.
have
Suppose
to know how to read papers then. I think
yeah.
that is something
Yes.
that if you're looking at case
Yes.
series and doing it, or you're looking at RCT and doing it, or a Cochrane and doing it, I think that's where we need to have how to read or how to interpret journal articles.
Right.
Yes.
I would like to say that we already had a NIPGT fiasco where some people's personal interest was involved. Here is where we need to be very sincere and honest with our patients. The counseling is important. If the patient says, I want to do NIPGT, they have to be informed that these are the false positives, these are the false negatives, this much is the chance, because it is their money, their time. If they are 100% convinced, then you have to do it. But if you are able to convince them on a scientific background, then you can go with anything.
So for me,
You can
it is
have
like
the add-ons, but let the
whatever
patient choose
data
it.
we
You can have the add-on.
See,
whatever data we have, I'm sorry. So you have developed your own data. So you have the statistics in hand when you're going and talking to the patient about particular add-ons. In our laboratory, it is the same happening. And you are telling the patient, and it's like recommended only for the indicated patients. You're not giving that to every patient. And you are going to tell the patient, this is the data. And never we had a detrimental effect from any of the add-ons. No, it was almost equal or slightly higher in some of the cases. So we tell the truth. And I tell the patients it's always 50-50 because you may be falling into this group or that group. That's it. Because for a particular couple, how it's going to work, we don't know. So we give that very positively. And obviously the finance matters, though, so that we have a different set of counselors so that we just make the patient can get convinced with the add-on if it is necessary. Not the first cycle most of the times, in the second cycle. Yeah.
Unbiased data and both side of information.
Yes.
Transparency here. That
Of
is
course, yes. Yeah.
transparency. Nancy, you want to add?
Yes. Dr. Priya already said that there are few patients who need tailored approach, right? So tailored approach is okay. That is fine. For those patient, add-ons can work. But see, hope is very powerful, but so is honesty. We can talk about the data we have. If the studies, if we have low evidence-based, low to moderate evidence-based studies, it is just a marketing pitch. If we have higher studies, plus we have our own data, we have our own interest that we can make this happen through this. That is important. Similar, equivalently with this also, we have to make sure that prevent overuse of treatment, overuse treatment, anything. We cannot just give patient everything and anything if it is not required. And unrealistic expectation should be avoided, and also avoid unnecessary cost to the patient. These are the few things which should be taken into consideration.
What we define as endpoint as embryologist is very important. When we say, it gives good result, is the result just a pregnancy or live birth? What happens to things like, for example, I will just take one small, for example, artificial oocyte activation. We don't know what is the long-term implication of it after birth, and studies have not been done. And the epigenetic changes could be, there is no question around it, it could be epigenetic changes. So how do we say where to stop, what to try, what not to try? It is a very difficult thing to, balance. So endpoint should not be considered just as a pregnancy and a birth, it should be considered as a lifetime of that individual too, when we study the research papers.
I agree. I mean, to tell you a small anecdotal personal experience, a few years ago, a lot of years ago, just to follow up on our birth is children born out of our culture is very important. I mean, I had 2 children born, like, little with the cardiac defects, congenital defects. And so I was worried, like, I've never had something like that. So I went ahead and checked my register, and I saw that I had just changed a media, and it was a different company which I had changed, and exactly in that particular I had just used for that patch, because the one I generally use was not available. And so these both different patients had given birth to children with the congenital heart defects. So I mean, it was like 2 years later, it was like they came back after 6-7 months for FET, and then we transferred, and then they had. But then it is important to know what is the result of our culture. It might be difficult in large performing labs, like high turnover labs, to go through it, and especially for embryologists to know, because you may not know how the history of the child. They may not even deliver at your center. But I just had all of that at my hand, so I could see that it was that particular culture media that got it. That was the only factor which was between everything. So I think that's a very important point, that we have to know what is happening to the children born, and that's where reporting of all our cycles and the outcomes becomes important, which probably would be in place in our country as well as per the law. Yes. Can we go to the next question, Manisha? Our time is already out, so I think we might now have to wrap up soon.
We can take it beautifully summarized, Dr. Priya. Actually, I wanted to hear these things. So now again, a rapid fire. Which innovation have shown measurable improvement in lab outcomes? Quickly, one by one. Anything?
Automation in semen analysis.
Okay.
Hands down. Because inter-user, personal usability.
No reasoning. Just the name. Just the name.
CASA.
Microfluidics.
Nancy, Vanshika.
Artificial oocyte activation.
Great. Nancy.
Time lapse for deselection of.
So we have already discussed this question. So anybody wanted to add anything, they can say. And moving to the next question.
Sorry, I jumped in because I have to leave, but here I can comment. There are 2 measurable innovations in the history of IVF which have changed the way we do ART. Is ICSI and vitrification.
Yes, major breakthroughs.
ICSI and vitrification are the 2 innovations that have altogether changed the IVF, the way we do IVF.
But Sanjay, they are not the add-ons anymore. They are all regular part and parcel of ART right now.
Manisha asked about the innovations, not the add-ons.
Okay. They are part and parcel. Without that, our IVF lab doesn't work.
Wonderful. Sir, please be with us for one more question. I really wanted to have
Just the last question. Last one.
Question. Yes. How do you assess embryologist competence, and what framework should we be using? Embryologist assessment, are you doing in your labs? Do you think?
Yes, we do. Yeah, we do. And we have the logbook designed for every procedure, from andrology to embryology to cryopreservation, and patient communication, etc. Everything. And they have to fill in certain number of cases, and that has to be initially they will observe. Then they will be doing it under observation, and they will do it independently. So there are different numbers, same numbers for each criteria.
Yeah, true.
And finally, it will be final assessment from the lab manager, and there is a signing off procedure.
Anybody else?
So it goes. And when it comes to kind of embryology procedures, it's like 25% eggs And you have, for example, if it's 60, 25, 50, 7500, something like that. So crucial procedures, you may have to really just take a little longer with more number.
So I do video recording of the ICSIs and vitrifications so that the person who is doing it, we get to know what they have done, and obviously the data logging, and at the end of the day, we mention whichever process, if a person has done vitrification, that person has to do the thawing. You cannot allow them, one is doing vitrification, others doing thawing. One person should do the whole process, the full patient case, only then it is justified. Because then interpersonal changes can bring about difference in the case. Even like making the dishes has to be made by the same person. So these are the small things. If the person does one case fully, so that that person is trained completely, and you cannot blame that this is because of you.
No, it's how to assess the competence. So it is.
So we one point I would like to add.
Who's done what process, who's prepared the semen sample, who's prepared the dishes, who's done the ICSI, who's done the vitrification, who's done the thawing, who's done the transfer. So that is how we make a chart, and at the end of the month, we see the cases, we see the end result, and see where anything has gone wrong and who has taken out the media, who's done this process.
So are you limiting to the time limits as well?
Absolutely. So time limit, a very nice point. Every time, if you're doing simple, that is, you're putting the oocytes in hyaluronate, denuding the oocytes.
Right.
This should be done within this amount of time. It should not cross the 1.5 minute line. If it is crossed, we mentioned 1 hour, 1 minute, 30 seconds extra, or 2 minutes, whatever. So these are the things that you are slow. So next time we work on that, you need to be faster. Simple loading time takes 90 seconds, 30, 30, 30. If it is taking more, we mention it for every person. There is one person who's standing behind just with a timer and writing down everything.
So one more point I would like to add, this is the embryo grading. That's where we are going to have bias from different embryologists doing it.
Right.
A different system of everyday audit, because it's multiple centers, and then the pictures are taken for every embryo frozen. That is mandatory nowadays, and it is posted in the group, and the grading is cross-checked by another one. So it's just gone through by others as well, so that we have a cross audit. And inter-observer variability, at times every month, not every month, every quarterly, I will just give a set of embryo pictures and everyone has to grade them. And then we need to see, like, at least to minimize some kind of errors. This is what we do for embryo grading. That's where we see the variability highly.
Very beautifully summarized, Sarguna. But still, I believe while doing a gradation and analyzing gradation by pictures, it is we are reaching near to 90%, but 10% benefit of doubt will be there at times, because at times poor embryos are giving us pregnancies as well. So that is there. So finally, coming to the end, not taking much of your time. But before that, anybody would like to add anything here?
I would like to add one point here. Yeah. So my criteria to assess an embryologist are very simple.
Okay.
How much they are knowledgeable, how much they have this IQ of adapting or going into the newer technologies, and their reflex actions, how much they are fast and furious in, like, suppose there was a fluctuation in a QC, how much they fastly and how much they instantly reviewed that, how much fast they have corrected that QC deviation. So I think skill is something, a skill of technology is something different. But yes, day-to-day working aspects, day-to-day nature of working inside the lab, that is something else. So I think, yeah.
Beautifully said, but I would like to add 2 more things: their attitude and team spirit, how they are behaving with their teammates, with their seniors, and how open to punctuality means general attitude. That is also counts a lot. How adaptable,
how calm and composed they are. Personality traits make a difference. So at the time of recruitment itself, we are just seeing that, and they have to be really calm when there is a problem. That's something very, very important.
And how they behave when there is an unfavorable situation.
Yeah.
We are ready to come on a Sunday and a holiday.
Yes, exactly.
So Rahul,
Holidays.
are you? Do you make your embryologists play video games or online game to assess their high?
I give them 1 hour of lunch break. Go ऐश करो and check your phones, go watch reels, do anything as you like. So it's basically a human mind that need to be refreshed. they should have a fresh air. They are working inside the lab tirelessly. At least tell them to go out, have some fresh air, come back, have your food, come back and work in the lab. This will ultimately not only it will increase their efficiency in lab, they will have this tendency that yes, there is one person behind us who is taking care of us. So it will basically give them a
Team
faith.
spirit. Good team
Yeah.
spirit. I must say, very good team spirit. So now, actually, this beautiful discussion is bringing us to end of today's conversation. The last thing I would like to know from all of you, for the teams who are establishing a new IVF lab, what are your 3 most critical pillars based on empirical experience that must be prioritized for building reproducible success within first 100 cycles? Very quick. Dr. Priya's style, rapid fire. First 3 essentials.
Air, water, and man.
You are asking.
Yes, yeah. I mean, air quality, your culture system, and your manpower, and that's it.
Yeah, I think that sums it all.
Yes.
Yeah, that's your.
Pratik is
That's
here.
all you need
Pratik
to
is
keep
here.
looking at
Pratik.
every time.
Temperature. Can I actually add one point?
Definitely.
Because
Yes.
I
As
think
long as you will gift us that automated system.
Just one block of it is also enough. One block.
Yes,
okay,
go
so
ahead.
so the point I have to add is that no matter where you put the IVF center, you have now ways to put it up at any place. Doesn't matter what, if it's middle of a busy area or in the outskirts. Reproducible success rates cannot be measured because you don't know the quality of the patients you'll be getting. It could be good prognosis or bad prognosis. So you have to keep that in mind. So 100 cycles, I don't think is the benchmark you should go for, because the type of patients you get really affect your success rates.
Rapid fire. Yes. Yeah. I like that from Priya. Hierarchy, the panel should be only rapid fire. Otherwise,
Rapid
we
fire, just answer, and
Yes.
that's about it.
Otherwise, we take the
I'll
liberty
just
of
put in.
talking too
I'll
much.
just put in my 2 cents.
Yeah,
One
it's
single
just one
point.
shot.
I'll just put in one single point. When you have made the lab, do not do cases for next 3 to 4 months. Let the lab breathe. Let the VOCs go out. Then start your lab.
You go on a holiday.
No, we are working in other lab. ये तो नया lab है.
That is very important.
Very important.
That is
for all
nice.
of us
So
to
I
have a
guess
break.
that have we completed all the questions that you wanted?
Almost, Dr. Priya. All yours.
Okay, so I guess that was a great discussion. Thank you so much. It was lively, and myself and Manisha, we had a great time, like at the Slugfest sometimes as well. So we loved it with our coffee, and I love the way you all responded to that single one-word answer rapid fires, because that saves a lot of time and it gives a lot of information. So thank you so much for sharing your experience, your expertise, your time, and for taking your time out at this point of the day. And thank you so much for sharing your knowledge as well. Thank you for Manisha as well, and Dr. Monica for having me here. And have a great time. Thank you.
Thank you, Dr. Priya, for being there. You made this conversation so lively, and with your expert comments. You are actually an expert, and you have added so much value to this conversation. Thanks for being there. Thank you to all my panelists, to Dr. Monica. And I hope this exchange gave us all something to take back, not just pointers or protocol, but the perspective. Let's keep these conversations going on, because in the end, that's how we grow, not just as a professional, but as a community, as an individual also. Till we meet again for another round of coffee and conversation, take good care of yourself, keep doing the wonderful work you all are doing, and be the blessing in somebody's life. Thank you so much. Thank you. Very good evening.
I applaud Priya for taking this panel, the definition of panel into different dimension. That's a rapid fire. I think we have to have all the panels with the rapid fire. One sentence, one word is more than enough. So that then otherwise we just keep talking. Yeah. So Priya has to have that.
Since very beginnings, initial days
Yeah.
of age, and she is very fierce, very quick, and very to the point. I really appreciate it. And
Yes.
Thank you all.
We don't want long answers. We want just one multiple choice
Yeah, just
question. What
one-liners. That's all is every
Wonderful.
definition is always one line.
From
Thank
now
you.
onwards, we will not have panel discussions. We'll have rapid fires.
Yes,
That's more interesting
it was
too.
it was essence of a coffee with the Priya and Manisha. Rapid fires has to be there.
Rapid fire with Priya and Manisha.
Manisha.
Yes.
Thank you all.
Thank
A
you,
big round
thank
of
you all.
applause. for
Bye-bye
everyone.
and goodbye.
All yours.
Thank
If any
you.
moderator is there, I will stop sharing my screen.
So thank you very much, everyone. And it was really wonderful, this coffee session. The So I just wanted to ask a question to Priya and Manisha. Nowadays, like we personally, we are having this all stainless steel lab now, wherein they put the steel sheets and it's like top to bottom steel with steel doors. So are there still VOCs in a steel? Yeah. So the VOCs, there is no paint, there is no tile, there is no adhesive. And
The VOC does not come just from the walls and the panels. It is from you, me, the
Yeah.
dishes that we use, the carbon dioxide to the trigas
Air
that we use. Everything that goes in and out of the lab is VOC. From
Yes,
anesthetic
the way
gases
you are
to
bringing
everything is
your
gets
sterile, the way you are bringing in your sterile, like packing of petri dishes, they are bringing in VOC along with you. Your clothes, they are bringing in.
Even too much talking in the lab can cause a lot of VOC changes.
One important thing which nobody talked about is using shampoos and perfumes and nail polishes. That is the maximum source of VOC. If you are using, stop using it.
Yes.
Actually, Dr. Monica, it is said that we don't walk fast or we don't make any lot of people in the lab or do like, running around in the lab because that by itself
Great.
brings in the VOCs. So
What, ma'am, I can
You build
give
a
some
lab,
info
take a
to this.
for 3 months. So that is okay. When you build a new lab, you take a break for 3 months, then start operating that lab. But the day-to-day VOC, you have to control by your activities. Like Nishad said, no nail paint, no perfume, no leaving hair open,
Right.
like all those things,
Right. And no unnecessary allowance of unnecessary people
yeah.
inside the lab. Very limited access to the lab.
So the
Then
teaching,
you have to instruct the patient also. Let us say the patient is undergoing an ovum pickup or an embryo transfer. The patient can come in with VOCs also because
We
usually
made it a point that
transfer.
they should be nail paint free, they should be perfume, and
Yes.
this is SOP in our system. Nurses take
Also,
care.
how you reduce your VOC by increasing the number of air exchanges.
Right.
Because the airback system is there. That is one thing.
As we
Second
all
is
have
having
discussed, as we all have
positive air pressure
from
also
where
makes a
we
lot
are
of
taking
difference.
the air for air exchanges, from where we are taking the air for air exchanges. So proper, like in my hospital, we have a cleanest air, but suddenly we have seen a drop in KPIs because all air AC vents were there from where we were taking the clean air for our AHU.
Yeah,
So that then
it is
changes.
a well-known fact that I remember we were using the water jacketed incubators before. Once upon a time, they were more sturdier than the air jacket that we are using right now. And it is a known fact that the open air in the veranda is cleaner than your IVF lab air.
The VOC meter will always tell that.
Yeah,
Because
so
of the good air
it
circulation.
is the outside. You keep in Monash, we used to keep our water jacketed on the corridor. And we used to have excellent results. There was no difference in our culture there. I mean, not in the IVF, but in our laboratories, in our practice.
At Monash, they constructed a new restaurant just below the lab, and the mouse embryo blastulation rates dropped significantly. And till date, they have not come back up.
Oh, okay. But this was in our practice. So water jacketed are great. The corridors are great. As long as we don't have too many people walking in and out all the time. That's one thing.
Right. So everything can impact.
So
Yeah.
can't really express in words how wonderful it all has been, Manisha. The dialogue which we started a month back, it's finally culminated and ended very brilliantly with the two of you. And the way you involved these experts was just awesome. Apart from the talks, which laid the proper foundation. So, really, the Synergy Academic Club is grateful to all of you dignified experts to be here and to have given so much of the piece of your knowledge to all audience, taken so much of pains to put it together. And we would definitely have a dialogue again on some other great topic from the leading embryologists of the country. Thank you so much.
Thank you. Thank you for having me.
Thank you for
Thank you,
giving
Priya.
us a chance, ma'am. Thank you so much. It is a pleasure being with you. Thank you. Bye-bye.
Bye-bye.
Thank you, everybody. Thank you so much.
Thank you.
Thank you.
Thank you so much. Thank you.
Bye-bye.
Coordinate.
Bye.
In May, we'll be having 2 more Synergy programs, Synergy 14 and 15, and we are starting a brand new series with ISAR in the month of May, which will carry on for 10 episodes. For that, all the ideas are welcome, and I think Shweta Agrawal is in charge of that. So let's look forward to more dhamakas in May. And a happy summer vacation to all of you. Bye-bye.
Bye-bye. Bye,
Bye.
ma'am.
Bye.
Good
Good
night.
night. Thank you, Vishal. Thank you. Bye.
Thank you, ma'am. Support team, end the meeting.